of the survey, which we were doing for the last 1 week. The survey was quite intimidating, as I got the feedback from many of the people who filled the survey and were my friends. Ki, Srishti, what is this? You are asking me how do I want to die and where do I want to die? It's like, haven't you ever thought about it? Like, अभी तो इतने काम बाकी हैं, अभी तो बच्चा छोटा है, अभी तो घर खरीदा है, अभी तो कुछ भी नहीं हुआ. So it was really an interesting thing to ask people about how they want to die and where they want to die. So let me go through this presentation, and I'm really thankful to Dr. Ravi Jain. He is our assistant professor in Department of Critical Care for preparing this survey and for making a summary of this survey. He had been last night he was up till 2 o'clock. So thank you so much, Ravi, and thank you for letting me present this today. So this is the age group division of the people who filled the forms for us. Maximum people are from the age group of 31 to 40 years. And then the next age group is 41 to 50 years. So this is how the age groups of the people who fill the survey for us is. This pie chart represents that people belong to which fraternity. So the people who responded, most of them were from Department of Critical Care, then Internal Medicine, Anesthesiology, Pulmonology, then Pediatrics, and there was a big group of others. And in the others, this is the pie chart where we can see people from community medicine, endocrinology, neurosurgery. So these are the people from the other fraternities. We got around 200 people who have responded. Many more people are responding, but since we wanted to present you the results of the survey, we closed the survey for another few hours. This is the academic qualification distribution. So most of the people have are belonging to the student age group, MD, MS, DNB. They've done the MD, MS, DNB, I'm sorry. Then 24% from the super specialty, 12%, 13% from the DM, MCH, and 12% were MBBS, and rest were the others. This is like the position of the institutional hierarchy. So it is interesting to see that we got the maximum results from the head or director or the professors. So as we can see, mature people were more interested to answer the survey. Then next were the consultants, academic consultants. Then 13%, 12.9% were the non-academic consultants. So this is the distribution, right? They had worked before, maximum of them had worked before in the government medical college, then private-owned institute and corporate multi-speciality hospitals. And some had worked in the private medical college as well. This was a very intimidating question. Like, had they received any kind of formal training before for soft skills of or end-of-life care or brain death or organ donation in the last 5 years? And surprisingly, in fact, I should say we should not be surprised, 77% of the people have not received any formal training before. Then how would you rate your soft skills and communication with the patients or the next of kin? So many people have responded 3 and 4. So that means they do feel that they can answer the soft skills correctly. And how would you rate yourself for soft skills and communication with the professional colleagues? So many people feel that they are comfortable talking to their professional colleagues. So that's around 4 or 5. Then have you ever decided on medical futility and conveyed the stakeholders? So again, 27% of the people said no and 72% of the people said yes. How would you rate your skills of end of life care communications or the breaking the bad news? So I think many people have responded that they feel a bit uncomfortable talking about the end of life care. So they rate themselves as 3 or 4. And 14% of the people rate themselves as yes, they are confident about their skills of communicating with the patients or relatives who are bereaved and dealing with a dying patient. Are you aware of end of life care policy in our institute? So 40% of the people have said that they are not aware of it. So I think it's an eye opener for all of us, and I would like to minimize this and show you all that we do have our end of life care policy, which is in place in the hospital since month of August 2021, July 2021. And the document was prepared by the Department of Critical Care and Palliative Care jointly and approved by Dr. R.C. Gupta sir, our medical superintendent. So we do have the end of life care policy. We have adopted these policies with the help of AIMS New Delhi. So we do have the end of life care policy in our hospital. Coming back to our survey, so interestingly, 40% of the people were not aware about the end of life care policy in their institute. 13% are aware but have never used it. 22% are the people who are fully aware of it and have used it. And 12% are the ones who are aware about it but never happened to read it. So that was the interesting result of this question. How you decided medical futility. So most of the people have answered that they briefed their point of view to all the caregivers and then taken the decision based on the input, which I think I would do myself if faced with such a situation of dealing with a very critically ill dying patient in my intensive care unit. I would like to have on board most of the consultants I'm working with and the allied consultant who are involved for their inputs. If you ever be in case of terminal illness, what specific support or service would you like to receive in order to your own or loved one's process of dying and death? So it's interesting. 65% of the people want to receive palliative care at home. Care at hospital but not being shifted to ICU, it's 10%. Shift to ICU, but DNAR, that means do not resuscitate, do not do CPR on me, is 15%. And only 9% of the faculty members wanted all critical care support, including ventilation and all forms of life support. I think this is really interesting. In case of terminal illness, where do you want to have your last moments? I would say Hawaii. 78% of the people wanted to die at home. 10% have never thought about it. And it was really interesting. My better half was sitting next to me and he was like, Srishti, what is this question? Where do I want to die? Of course, you are an intensive care physician. You will take me to the ICU and hook me with all the machines. I said, Rajiv, no, I'll follow what you want to do. You can write your advanced directives. And it was interesting. He's like, what is that? So I'm really waiting for him to listen to what are the advanced directives today. And so that was the result. Have you ever came across the concept of bereavement support? So 52% of the people have not come across. Some of them even asked me, what do you mean by that? And 16% were not sure and 30% answered as yes. How have you ever referred someone to bereavement support system? 55% people said no. 30% are not aware about any such system in their setup, and 14% people have said yes. How long the bereavement support can be given? So 79% of the people have answered that they are not sure about the upper limit. And then rest of the answers are equally distributed, I would say. So bereavement support is something very organized abroad. If we go, as soon as the patient dies or is about to die, the bereavement team is called in the hospitals. I've worked in NHS, so I can say about that. And the bereavement team comes, talks to the family, supports them before dying, during the process of death, and as long as the family wants after the death. So that was the result of the pre-conference survey. I'm sure most of you will listen to many of the answers and would like to change your answers as well at the end of the session. So this was the result of our CAP Gap survey. We are really lucky that this conference of ours was supported, endorsed by the Indian Institution of Critical Care Medicine, Indian Society of Critical Care Medicine, Indian Palliative Care Institution, and we are really, really lucky and thankful to Mahatma Gandhi University to give us an opportunity to bring this difficult topic on stage today. So we have some videos by some of the people who have supported us today. The first video I'll be showing you is by Dr. Nagesh Simha. He's a general surgeon, but he is the president of the Palliative Care Society in India. And he runs a hospice care institute in Bangalore named by the Karunashray.
Communication involves a process of gathering and
So we were seeing the video by Dr. Nagesh Simha, who is the president of the Indian Society of Palliative Care Medicine. And let's see what's the message he wants to give us.
Communication involves a process of gathering and imparting information. It is a vital part of therapy and, if done well, has great therapeutic value. Communication in end of life care is more difficult as it happens under very stressful and uncertain circumstances. A consensus group identified 7 domains for high quality end of life care in the ICU. Patient and family centered decision making, communication, continuity of care, emotional and practical support of patients and families, symptom management and comfort care, spiritual support, and emotional and organizational support for ICU clinicians. Outcomes of end of life care are better if communication is collaborative and optimal, paying attention to values and emotional content. It also influences how loss is processed. Studies have shown that a vast majority of patients and their families do want information about the status of the illness. This has to be given in a compassionate way. While you cannot make bad news good news, by following well-researched methods helps in making it easier for everyone, the giver and the receiver of the information. One of the common approaches is the SPIKES protocol. S for setting up, P for perception, I for invitation, K for knowledge, E for emotions and empathy, and S for strategy and summary. The core of good communication is patient-centeredness. This includes fostering of healing relationships, exchanging information, responding to emotions, managing uncertainty, making decisions, and enabling patient management. Asking open-ended questions gives more latitude to persons and facilitates therapeutic communication. The family meeting is the fulcrum of such end-of-life care decision-making. The objective of end-of-life care is to achieve a good death, with emphasis on quality of life and quality of death. The process of providing good end-of-life care follows a sequential series of steps which involves recognition, decision-making, initiation, providing the care, bereavement support, and finally, and very importantly, the review of the care process. Appropriate communication with the patients and their family ensures that the psychological and spiritual needs of the patients are met and that the family is aware that the patient is dying. Time plays a very important role in critical care. Speed is of essence and it becomes necessary for the communication to be many times more direct and urgent. A good strategy would be to engage in empathetic communication right from the time of admission, when you may have greater time to understand the family and the patient. Finally, it is imperative that all those involved in the care of patients undergo the necessary training in communication skills. Thank you.
now invite Dr. Lalit to please start the session formally, and we have some more videos which we would play in between.
So very good afternoon to all of you. I am very thankful for all of you to spare time on this busy weekday. I am Lalit Mohan Sharma. I am working in Department of Medical Oncology in this hospital only. And we were tempted, in fact, to do this meeting for very, very long period, almost 6 months or more. I am thankful to Professor R.K. Mani sir, who has spared time and agreed to come on our invite. In fact, this is very, very close topic, and we realize that especially while working in oncology, I realize that I do not have a formal training, and how to talk, nobody teaches us. So whatever we learn is based on our own experience, based on the observations from our seniors, based on individual perceptions. So is there any formal way? Professor Mani and other faculty members, they will definitely share their views on that. Before we start, may I request once again that those, welcome sir, thank you so much sir. So I request once again that those who have not filled up the Google survey form, please scan them from your table and send them online so that we can have more data. And with this, I invite Dr. Sudha Sarna, who is Professor in Head Department of Palliative Care in MGU MST, to come here and say a few words to start today's meeting.
Thank you, sir. Good afternoon, respected Dr. R.Q. Mani sir, Dr. M.L. Swankar sir, Dr. Hemant Malhotra sir, Dr. Parvesh and Dr. G.N. Saxena, and good afternoon to all the audience present over here. So why we are here today? We are here to talk something about death. You must have listened the song, Zindagi ek safar hai suhana, yahan kal kya ho kisne jana. Life is a beautiful journey. And what about death? It is unpredictable and it is inevitable. So why are we afraid to talk about death? Good death is the right of every human being. Why should they be deprived of good death? So we will be talking about quality of life and quality of death. It is very unfortunate that in a survey done in UK in 2015, India ranked 67th amongst 80 countries for quality of death. Here comes the need to start services for the dying patients, services for the patients who are approaching death. So we shall be discussing about the end of life care issues, what are the policies related to them, what benefits or what mode of treatments can be made available to them. In modern society, lifespan of individual has increased because of the latest modern treatment. Earlier, patients used to die in the homes, in the company of loved ones. But now, today, they spend their last days of life strapped to tubes, cannulas, and so many other things which increases their suffering. So when to stop all these interventions? So we will be discussing about the end of life care guidelines, when not to do such interventions or when to hold such interventions. At times, we as a doctor feel difficulty or feel dilemma about when treatment is no longer appropriate for the patient, how should we communicate it to the patient? How can we communicate the futility of treatment to the patient? How should be patient involved in, patient and family should be involved in this discussion, where this discussion should be made, and so on. So there are so many questions sliding end of life care of the patient. So we will be discussing this also. We will be discussing the guidelines that has been formulated to guide such in such condition, so that doctors, they are ethically correct in their treatment, but yet they are medico-legally safe. That is very important, because sometimes we are not aware of the guidelines and we are not able to provide appropriate treatment to the patient. So this is our aim, that we should discuss about end of life care to the patient, given to the patient, so that in our daily practice we can implement them and we can use them. Everything that is done by doctor should be done in patient's best respect. That is, autonomy is to be followed. Every patient has its wishes about the preferences of the treatment, where he want to die at the end moment, and there are so many questions related to the end of life care. So we will be discussing about what is living will, what is advanced directive, and Dr. R.K. Mani sir, I'm really honored and privileged that he is here and he will be guiding us through these questions. End of life care does not stop at the death of the patient. Family needs to get care and support after one has lost its loved one. So we have our bereavement support. We should be discussing about what it is, where you can go, who can do this support, so that patients attendants come out of this grief easily. And even Srishti just showed me that in our institute only 60% of doctors or faculty, they were not aware of this support system. And to my surprise, even more than 50% of doctors, they were not aware of end of life care policy in our institution. So we will be touching all these points, and our aim is to get answers to these questions so that we can implement it in our day-to-day practice. A few lines have come to my mind. रोते हुए आते हैं सब, हंसता हुआ जो जाएगा, वो मुकद्दर का सिकंदर जाने मन कहलाएगा. This is what is the aim of end of life care, that when a patient is approaching death, he should go peacefully and with dignity. So let's talk about this. Let's get answers to our questions, and let's get the guidelines from our expert. Thank you, sir, again for being present here. Thank you, everyone.
So thank you so much, Dr. Sudha Sarna, for your excellent, emotional but power-packed speech. Thank you so much. So with this, we will start the formal session. And may I request Professor R.K. Mani sir, who is our guest speaker today, to be on the dais, please. And may I request our emeritus chairman, Dr. M.L. Swarnkar sir, to please come here on the dais. Professor G.N. Saxena sir, who is May I request Dr. R.C. Gupta sir, our medical superintendent, to come on the dais, please. And may I request Professor V.K. Kapoor sir also to please come on the dais, please. So now may I request Dr. G.N. Saxena sir to say a few words about today's activities.
Well, good afternoon, everybody. It's indeed a pleasure to have an eminent personality, Dr. Mani, with us to talk to us about a topic, and Dr. Sarna has already talked to you about, is the main thesis or the main topic for the day. And we'll have Dr. M.L. Swankar to guide us on this. And we welcome him on this dais. And I'm sure Dr. Swankar will have a few gems from his religious books, which he has always been doing. And I'm sure all of you will not just listen to the thing, implement it and talk about it in their own departments. And I'm reminded of a saying from Shakespeare long back. It seems to be most strange that men should fear death, because death, a necessary end, will come when it will come. So that should be the driving force in our life, that we are all prepared, not just for ourselves, but from the persons that we take care of. As doctors, we have a dual responsibility, not just for the patient who's living, trying to get him back, but when we know from the existing science that this is all that we can do, then how to make sure that the end is comfortable, for the patient and the family. This is what we'll be learning about in the afternoon, and I welcome all of you again for this talk, though it looks so serious, but I'm sure it's a very useful topic. Thank you.
Thank you, Professor G.N. Saxena, sir. Now may I request our emeritus chairman, Professor Dr. M.L. Swankar, sir, to say a few words of wisdom and to give us some gyan about this life and death.
अगर लाइफ और डेथ का ज्ञान ही होता तो बात ही क्या थी. Honorable Dr. R.K. Mani sir, our chief guest and today's keynote speaker, distinguished guest on dais, of the dais. I think today's topic, let us talk about death, is very, very important. And we have to see it in so many aspects, apart from a just medical or scientific aspect, because the religions are involved, society is involved, family is involved, his or her will is involved, and what is the law, what our country permits, what our constitutions permit, that is the most important. I think, to best of my knowledge, sir, this willful death or to take the support is not permitted by our constitution. Am I right, Dr. Mani? No, suppose if the patient is there in the ICU, can we withdraw the support?
We will come to that. That is the essence of the
Yes,
talk.
so this-
It has
okay,
to, the theme has to be developed a little, sir. Yeah.
because I'm not aware of this. To my knowledge, I was under impression that we cannot withdraw the support. There are things like living will or do not resuscitate, DNAR sort of things, and other things are also there. Like if you go by religion-wise, in Muslims, in Islam, the only Allah has the right to take the life or to give the life. So there it is not permitted to withdraw the support. It's just, if I am wrong, please correct me. Same is with the Christianity, but Christianity, one of my friend was talking to Archbishop, and he was saying that yes, it is the God who takes or gives the life, but with the evolving science, something can be changed according to the circumstance. For example, before 500 or 1000 years, if somebody says that earth is moving around the sun, he was sentenced to death. All right. But now it has changed. It is the earth which is moving around. So they have adopted that if something can be done, then it is very good. In our Hindu or Sanatan Sanskriti, we think Atma as totally separate from body. शरीर अलग है, जीवात्मा अलग है, और जीवात्मा जिसको शरीर ही बोलते हैं और शरीर अलग है। और आत्मा को जैसा कि भगवत गीता में बोला है कि ना इसको कोई छेद सकता, ना इसको कोई गला सकता, ना कोई जला सकता, ना कोई इसको मार सकता। नैनम छिंदन्ति शस्त्राणि नैनम दहति पावक न क्लेदन्ति आपको ना शोषयति मारुते। क्लियर कट बोला है। और दूसरा साथ में ये भी बोला है कि अगर आपकी बॉडी किसी के काम आ सके, बिकॉज आत्मा तो ट्रांसमाइग्रेशन है, it is not going to stay in your body, but this concept to me looks very good, that because each and every cell of the body has atma or pran jisko kehte hain, and suppose where we can save lives, a brain dead patient is there, where we can save the life by donating other organs, kidneys or liver or heart, then why not? And this is permitted as far as the religion is concerned. But what is the actual factual position? Dr. Mani will tell in the greater detail. I may not like to go into it. I am very innocent, or you can say not too much aware about this latest development, but I do know that sometimes it is a burden on ICU. You know that the patient is not going to survive, but you cannot withdraw the support. तो पेशेंट भी परेशान हो रहा है या उसको पता नहीं है परेशान हो रहा है नहीं हो रहा है, और फैमिली पे कितना फाइनेंशियल बर्डन आ जाता है, ये एक सोचने की बात है। कितनी रिसोर्सेज खत्म हो जाते हैं लोगों के। इवन यूके वगैरह में देखें, गवर्नमेंट के एनएचएस के कितने रिसोर्सेज हैं, महीनों तक आईसीयू में पेशेंट्स पड़े रहते हैं। तो ये कई चीज़ें जो डिस्कस आज अच्छी तरह होंगी, आई एम श्योर, and experts like Dr. Mani is sitting here. So all of us will be benefited and will come to know what is the current situation, what current law says about it, and how we can promote the organ donation also, if some relaxations are there in these things, which I am sure there. That is how this disease donor program is also going on. So all these things will be discussed, and I am really grateful to the Department of Critical Care and Department of Medical Oncology to organize this event. Palliative care, yes, Dr. Sudhasar Nazson. So all these departments, I'm really grateful that you are organizing such a beautiful topic, and the legendary figure Dr. R.K. Mani is there to deliver these talks and panel discussions. Thank you very much for inviting me. Thanks a lot.
Thank you so much, Swankar sir, for your words of wisdom. And now may I request Professor Dr. Hemant Malhotra sir to formally introduce our guest speaker. Dr. Srishti, can you help sir with the slide?
Thank you very much, Dr. Lalit. Dignitaries on the dais, Dr. Swankar, the Emeritus Chairman of this institution, Dr. Mani, our guest speaker and keynote speaker of the day and the expert, Dr. J.N. Saxena, our Pro-Vice Chancellor, teacher of teachers, including my teacher, Dr. R.C. Gupta, our medical superintendent, and Dr. Kapoor, the chief of our hepatobiliary surgical services, the other host departments, my department, Department of Medical Oncology, Department of Critical Care, Dr. Ashish, Department of Palliative Medicine. You just heard a beautiful introduction by Dr. Sarna. So, like the importance of this topic, I think it cannot be overemphasized. Somehow, even being possibly the spiritually most advanced and the most stable country of the world, the country to which most people gravitate to, come to for spiritual satisfaction, solace, that country somehow is afraid to talk about death. There can be nothing more certain than death. Every single organism on this planet
If born on this planet, it is going to die. But still, we have this huge barrier about talking about death. We don't talk to our parents about death. Our parents don't talk to us about death. Patients doesn't talk about that, doesn't want to talk about death. Attendants don't want to talk about death. So first and foremost is that we have to remove this mind block of this number one inevitability of an individual, human or otherwise, who is born on this earth. So are there any medical students over here? And are there any residents over here? Okay, so can you please tell me, were you taught communication skills while dealing with a patient who is dying in your undergraduate course? Just raise your hand if you were taught that. So we have about 20 students here, and none of them were taught this. I can vouch for that. When I did my, undergraduation, post-graduation, super specialty training in oncology, in a specialty in which very significant number of patients are going to die very quickly, I was not taught this. Were you taught in your post-graduation how to communicate with a dying patient and the family of a dying patient? Can anybody raise their hands? Yes or no? So again, this is one thing which we have to fix. We have our emeritus chairman here. We have our pro-vice chancellor here. Why can we not introduce this series of lectures to our UGs and our PGs, and familiarize them with this process? I think again, as Dr. Swankar said, there are a lot of confusions even in super specialists and experienced clinicians of his stature. He's been in practice for 40 years. I've been in practice for 35 years, and I am still not very clear that can I pull the plug of my terminally sick patient in the ICU? Will I be arrested for that? Will I be jailed for that? I don't know that. So that is what we are going to hear today. That is what we are going to learn today. And we will also thrash out a lot of practical problems related to death and dying and communication and the legality of the same in two panel discussions. So I'm very, very happy to see that so many people are here in this hall, and this is a topic which interests all of you, and it should interest all of you. So now I will quickly move on to introducing our guest speaker to you. Dr. Mani, Rajkumar Mani, is a clinician teacher par excellence, and you can gauge that from the fact that he is invited for 3 to 4 guest lectures every month. So we are really indeed fortunate that he has agreed to come and visit our institution and disseminate his knowledge to us. Thank you very much, sir. So he did his MBBS from the very famous Maulana Azad Medical College, 1973. So you are 2 years my senior, sir. He did his MD from Lady Hardinge Medical College and then fellowships from England, USA. He's presently the clinical director and chairman of critical care and pulmonology at the Yashoda Super Specialty Hospital in Ghaziabad, UP. He's earlier been the medical director and chairman of critical care and pulmonary services at several institutions. His special interest is also in sleep medicine. He has been a director of pulmonology and thoracic services and the medical ICUs of several institutions. He is the ex-president of the Indian Society of Critical Care Medicine. He's on so many committees, national and international, and I can list some of these committees: prevention of catheter-associated infections, developing guidelines for non-invasive ventilation, guidelines for venous thromboembolic disease. He's been the chairman of the Ethics and End-of-Life Care Guidelines, published way back in 2005. He is on the ICMR task force for development of consensus in end of life and palliative care. He is also on the task force of the DNAR guidelines, do not attempt resuscitation guidelines 2019 and 2020. He is the chairman of one of the task forces of end of life and end of life guidelines. He is the chairman of the multi-professional task force constituted by the Indian Society of Critical Care for end of life care. He has a whole list of awards and honors. So to cut a long story short, ladies and gentlemen, we have a true expert in the field. And सोने में सुहागा जो बोलते हैं, he is a wonderful orator. And as soon as I posted our program on our, we have a national oncology network. As soon as I posted the PDF of our program, I got so many inputs from oncologists from all around the country that, oh, we've heard Dr. Mani, he's a wonderful orator, and I'm busy in my OPD, can you record and send me the recording? So we will do that for all our oncology colleagues. And not only oncology, this is a topic which should interest every single clinician. Not only clinician, it should interest every single person, because this is what is going to happen to you, whether you like it or you don't like it. This is what is going to happen to your parents, and this is what is going to happen to your near and dear, and you have to talk about this. Get rid of that inhibition, which is, I don't know why and how, has been inculcated in our mind. So with that, it is my pleasure and privilege to invite Dr. Mani. We are very anxiously waiting to hear from you, sir.
It's always a great pleasure to be here in Jaipur. I have a long rishta with Jaipur. And true to their famous hospitality, Padharo Mare Desh, there's always a warmth and affection. And so you can't really refuse an invitation of such warmth. So it's a great honor to be here in this beautiful hospital. I'm fascinated by its, its size, its cutting edge technology, and absolutely amazing faculty. Dr. Swarankar sir, hats off to you. Hats off to you, and hats off to all the galaxy of stars you seem to have on the faculty. Thank you very much, Dr. Saxena. Thank you very much, Dr. Malhotra, for your such affectionate, words for me, and and my colleagues in the critical care setup, Shrishti, and then palliative care setup, Dr. Sudha Sarna. Now, thank you, all of you, for this great opportunity for this conversation. I think a lot can happen over coffee, they say, isn't it? Huh? A lot can happen in medicine, by the bedside, in this community, in the country, over conversation that are meaningful,
And it's not just about talking about death. It's having a conversation about things that really matter in medicine. It's about our health. Health is everything. Health of the body, health of the mind, health of the spirit is what our mission is, mission of medicine. So we are talking about what is holistic health. And if we don't talk about death, how can we talk about life? Okay. The modern medicine, the advances in medicine have unfortunately made us a death-denying, death-defying society which considers death as a defeat. And this has percolated into our consciousness in our practice. Dr. Malhotra said, why are we so, what is the barrier to talking about it? This is the problem. I think the modernity has impacted us a bit adversely. That we are not open to looking at life and death as a whole. We are looking partially. That is one problem. But there can be, death is not a vacuity, it's not a nothing, it's not a nothingness. Like clouds pass to water, to rains, so it is. Okay? It's a continuity. These are the words of the Zen master Thich Nhat Hanh. Now, with that introduction to what we are talking about, I will introduce you to this poem or letter written in Intensive Care Medicine, a European publication, or got the highest rating in intensive care. So it is on behalf of an infant born 4 months earlier. So it says, I was born premature 4 months early. You intubated me, put me on a ventilator because you could. And it goes on to say, you gave me surfactant to grow my lungs. Why? Because you could. And it goes on to say, I got a swollen head, so you put a shunt in me. Why? Because you could. And it goes on to say, then you made a tracheostomy because you could. You did all this because you could, and nothing in the end. In the end, I died on all this. Think, is this what I deserved? Now, the whole conversation begins with this statement. You could does not mean you must. There are so many things you could now. Science is advanced, technology is advanced. Has the human mind advanced? Has human wisdom advanced? Well, that's an open question. I'm not giving a rhetorical question. It doesn't mean because you could, you must. Okay. This is an important thought to carry with us by the bedside on our rounds. There is a modern dying paradox. Okay. Dying has become complicated, it's become medicalized because most who can afford go into the ICU. 20% of all deaths take place in the ICUs in the US. We don't have figures here, but I suppose whoever can afford goes into the ICU. It's medicalized, lonely, impersonal death, burdensome, painful, and expensive. But those who can't afford, they don't get access to the ICU, but they also die a miserable death because there is no palliative care access or palliative care orientation to their management. Now, disproportionate treatment is what is excessive treatment, what is not beneficial. What is actually harmful? Now, disproportionate treatment harms everybody, every stakeholder. To the patient, it harms by prolonging their death. Nobody deserves to have their death prolonged. Okay? A meaningful life prolonged, fine. A meaningless suffering prolonged is not what our objective is anyway. It's against bioethical principles. I'll come to that, why it is against it. For family, as Chairman Sir pointed out, it causes great economic distress, dissatisfaction with the profession, distrust of the profession, post-traumatic stress disorder in psychiatric terms. To the caregiver also, we are not spared. Okay? Ask the intensivist a close question. How does it feel to keep a patient knowingly, deliberately in a prolonged state of agony? It causes moral distress. It causes what is called compassion fatigue, right? You put yourself in the shoes of the patient and you don't feel great. And you do it day after day, you get sick, you get insensitive. Okay, that is compassion fatigue, and leaving work. You get disillusioned with what you're doing, and it may cause you to leave work. But you see, you can prepare well. This is a real life, okay, one of my collection. She died about 2 weeks later, but her children were there from various parts of the world, and we had prepared well, so we are laughing, we are smiling. See, every death is not a morose moment. Okay? A lot of times a celebration of a life well lived. You see, we should be enabling, we should be life affirming. If we affirm life, it is also affirming the meaning of death. Okay? Death is not a defeat. So doctors must understand. Look here, 10 to 30% of the ICU population die, depending on the case mix all over the world. This has not come down. Okay? So are you going to, for 1/3 of the patient, are you going to say, I have nothing to offer? It's not possible. We are caregivers. We don't give up on anybody. We may run out of curative treatment, but we don't give up on it. So we have to care for the dying, and we have to care intelligently for the dying. So how do we manage the dying and the grieving? Okay? It's not just the dying. On the other side, there's the family, the loved ones who are grieving. They may grieve even after the death. So death, dying and grieving in the ICU setting needs to be managed with skill and understanding. It needs a special set of competencies, right? They are being defined by all over the world by ICU, critical care societies. Out of about 45 competencies defined in Europe, 7 or 8 of them are of these skills of how to manage death and dying and for getting organ donation, okay, counseling for organ donation. Ethically grounded practice. Is your practice ethically grounded? Is it a reflective practice, not a reflexive practice? That is tested by end of life care, how you manage your dying. And quality of death and dying needs attention to these ethical principles. We must become familiar with communication and palliative care skills, as so many of our eminent speakers have highlighted. Legally informed practice, not legally frightened practice, legally informed practice. Community participation. It is not just for the doctors, not for the nurses. It is not just between patients and doctors. It is a conversation within the community, right, and in national policy. So if we look at briefly the ethical terms that we need to address when we discuss end-of-life care are these: autonomy, beneficence, non-maleficence, justice and equity, evidence-based medicine, setting the goals of care, communication, building trust, truth-telling, compassion, transparency, best interest, palliation, mitigation, all these words. Now, autonomy is patient right, okay, as a person, as an individual, okay, as a care receiver. But there are duties of the physician, beneficence and non-maleficence, to always work to benefit the patient more than any inherent harm that may have be there. It's inevitable with any intervention. Okay. So that is wo vada hai, okay, basic vada, that your benefit will override the harm, and you will not overly take risks. Okay. This is what is the best interest. Justice and equity means you do not discriminate between patients on any basis, Even in wartime, whether the enemy is there or our own soldier is there, you treat equally, right? You do not discriminate on the basis of gender, nationality, religion, sexual orientation these days, all right? On any basis, caste, whatever, your views, political views, nothing. They don't matter. Okay, you see your patient and you want an equitable distribution of resources as well. Okay. How is that possible if resources are overly used up in futile caring? Okay. That is the larger picture we have to see as a society and in the governance. So mitigation of suffering. Now suffering is the ultimate thing that we want to reduce. And that is there always, to cure sometime, to care always, isn't it? So suffering is maybe physical, psychological, emotional, and spiritual. Four. The four types of pain are addressed as the originator of Cicely Saunders said, or originator of hospice. Now, she said that there are four pains which we must address. What of India? Okay, let's talk the realities on the ground, and we'll develop a theme as to what we can do and what we can do better. We die badly. That's very clear. As Dr. Sudha said, in the dying index, the quality of dying index, we become a cropper. We become very low. So we come in the lower 15%. Okay, just ahead of some of the African countries. So palliative care is evolving. The government's new policy has recognized palliative care. However, there is not, I have gone through it, there is not a single line about death and dying in the quality. It's a pity, because we professionals haven't told them. Right? They know only what you tell them. We have not highlighted. We have not drawn the attention. We still do not have a national policy on withdrawal and withholding of inappropriate treatment. So I have given you these references which you can look up. There is an article written by myself and Roop Gursahani, my colleague, in the Indian Journal of Medical Ethics, that India, country not to die in. Okay, not a country to die in. Okay, it is the stark reality. Okay, I'll give you some case examples from my own practice. They are absolutely from the soil. Okay, okay, nothing fictitious here. A 40-year-old male, valvular heart surgery, post-op infection and sepsis. 3 weeks later, on mechanical ventilator, vasopressor, IABP support, CRRT, comatose. Familiar? Huh? Very familiar, right? Family anguished, again very familiar scene. Counseled, they accept the poor outlook. Financial crisis, unable to bear costs. Typical scenario, question 1. I'm just wanting you to be involved in this case, okay? So these are the questions I'm asking myself. What in your practice would you further do with further management? Continue full support till the end? Any hand? Any hand? Persuade family to take patient lama? Don't think what you ought to do, what you're doing, okay? Then you will raise your hands. What you're doing. De-escalate treatment. Oh yes, I do see honest hands there. De-escalate treatment unilaterally. Unilaterally. Okay? उनको क्या पता? मरीज को क्या पता? मैं सब कुछ जानता हूँ. ठीक है, मैं हूँ doctor, right? So this is the attitude we carry. Okay? Attitude of gradient, huge, vast gradient of knowledge and power. That is not caregiving, unfortunately. That is politics. So de-escalate treatment with documented consensus between family and physicians. What did we do? Now the treating team said family was told it was illegal to remove supports, so lama is the only option. Familiar? Unfamiliar. Family in a confused and distressful dilemma got embroiled in conflict with the treating team and hospital management. Shouting matches, show, right? Hangama. So the hospital management intervened and said second opinion. I was the second opinion, right? Not for pulmo, not for critical care, but to resolve this, because I was supposed to know a little bit more about end of life care. So I did go about it this way. Ensured open conversation and explicit prognostication with available options. Explicit, be explicit in your prognostication. If you think there is no hope, if you think there is nothing going on, all the doctors are saying there is no hope, Oh, the family is asking. I had another family member in the US. They were in a similar situation. They took off all the supports. Why, if it can be done in USA, why can't it be here? It's even more advanced country. Elicited from close family members what the patient would have wanted. Okay. He said, knowing him, he would not have wanted to be like this indefinitely, die in a miserable state. De-escalation decision taken and documented with signatures of both parties. IABP vasopressors discontinued, expensive antibiotics stopped. Now you are in the deathbed. You must receive your meropenem and your targocid and your colistin, your mecafentin. Now, is it a must? Like the pharaoh. Pharaohs used to take a whole lot of gold and everything along with them. Okay. So, are you going to take all these expensive medicines along with you? In fact, you're vitiating the atmosphere. You're doing harm to the ICU ecosystem and harming the future patient and yourself perhaps. But yet you continue with all that. We stopped all that. Palliative measures carried out with careful assessment and meticulous titration of doses. This is where Dr. Sarna and her team will come in. They will also come in conversing with the patient to allay their anxieties, to answer their questions, to put ethics and treatment in perspective. So what was the outcome? What is the outcome we are looking for in a case like this? Permanence of the patient, no death at all for anybody, immortality. That is not the outcome we are looking at. We are looking at a peaceful, distress-free end in a few hours. Gratitude expressed by the family. We resolved the conflict. They paid all the bills. They expressed gratitude and we built a relationship. Now, question 2 for all of you. It may raise some questions within you. On what basis was this decision taken? The decision is supported by the following principles. So, I recounted certain principles of managing patients, our professional obligation, duty of care of beneficence and non-maleficence and social justice, and our professional obligation to respect the patient's autonomy, not just physical autonomy, but their values, their interests, their opinions. Okay, that is the holistic, the whole person respect. Refusal of consent for treatment, duty of care by the physician team, and financial distress of the family. Look, autonomy was expressed through the surrogate, which is our duty to respect. Refusal of consent for treatment is always to be respected. Can we intervene for anything at all, whether there is a law or no law? Without consent for initiation or continuation of an intervention, you cannot do so. Duty of care by the physician team, yes. Duty of care involves weighing of beneficence versus harm and doing in the best interest of the patient, interest of the whole person of the patient. Not due to the financial distress. I am not taking a decision because the family can't afford. That would be unethical. That would be unprofessional. That's what drives you to say, take the patient lama. That is cruel and insensitive. They cannot afford, find a way to make it affordable or send them where they can be treated with less expense. But take an ethical decision at all times, whether the patient can afford the earth or cannot afford the earth. Even if the person can afford the earth, suffering is the same. Okay, suffering towards the end of life. Now, case 2 may be a little more shaking the system. Okay. Now, a 75-year-old retired bureaucrat, many years ago, maybe 15 years ago, on mechanical ventilation, transferred from another hospital with weaning failure. Okay, this was also familiar, many times happened. Month long he spent in another hospital, they can't wean, so they ring up the the so-called higher centers and they come. Several attempts failed over 1 month of mechanical ventilation in the referring hospital. On tracheostomy, fully alert, communicative through writing and speech. Metastatic prostatic cancer and other comorbidities including HOCM, okay, hypertrophic obstructive cardiomyopathy with chronic heart failure. They had gone through, all the available at that time treatment modalities and didn't. It's the end of the road. patient consistently desired not to be on mechanical ventilation or any form of life support. He had one daughter, son-in-law, and a little grandson. He said, if I am not in a position to play with my grandson, I am not worth living. My wife passed away 2 years ago. Now, don't push me too hard. I cannot take it. Okay? He told me. He said, doctor, I know you will be able to help me. Okay, he's very, his old Rob jo tha, as a bureaucrat, was still there. Even in his, I know you can help me. If you want any signatures, take it from me. I can even, dictate. You write a letter from on my behalf. I said, sir, this is not so easy. Huh? But I will try to help you as much as I can. What would you do for this patient? Now, honest hands should be raised. Continue full support till the end, saying law does not support WLS, withdrawal of life support. Okay, I am not going to listen to the patient. I am going to only listen to what the CJI might be saying. Okay. This is what you are saying in effect. Okay, I am not going to listen to this patient who is pleading. Okay, I am not going to listen. Sedate and paralyze the patient, gradually dial down. Okay, use subterfuge. Okay, cheat the law as well as the patient. Okay, and the family. That's another way. Send the patient home, Lama. Problem is solved. Okay, I will not face any dilemma of ethical dilemma, a moral dilemma, a professional dilemma. What I will do is do a ostrich act and say, go Lama, find this. Okay. So it's Lama, but actually a coercive act in which you induce the patient to go Lama. So it's a double lie. Fulfill ethical obligation. So are you going to fulfill your ethical obligation of autonomy, beneficence and non-maleficence? So I was in a real moral dilemma. I was writing all these guidelines. I said, you can't run away. Okay. You're writing guidelines, preaching to others. What are you going to do? Right? So I was watching myself carefully, what I am going to do. Initially, the physician team vary of WLST decision for the perceived fear of legal liability. And you perceived fear. Lot of our fear is our own demons. Okay? We must understand that. We are looking at the mirror. We may not be just looking at our face, we are looking at our fears also. Unclear prognosis in the short term. So I don't know whether I can really wean. If I gave it a good shot, maybe I can wean. Needed time to see whether weaning was possible. So I tried everything, called the cardiologist, can anything be done to the hook'em, dobutamine, all these things along with weaning. Nothing worked. After 3 weeks, the patient said, doctor, I have trusted you. Give me a date. Telling you verbatim what the patient, give me a date when you are going to stop all this. I said, sir, please, trust me. I am getting at it. Okay? Then I found a way. Counseling and documentation, directly recording. Now you see, the most powerful refusal of consent is from the patient, not family. If the patient is fully capable, you have to take directly from the patient. Talk to the patient. Patient gave me directly that I do not want to be on a ventilator. If I am weaned and I cannot sustain, don't put me back. Okay. So he was weaned, he did not put it back. We gave him anticipatory palliation. The family was with us, with their father. No, if father wishes, we do not want to be in it. Be a barrier. So there were family, physicians, concurrence, and decision was documented as per the ISCCM guideline that existed at that time. Okay. There was ISCCM guidelines of 2005 and 2012. Anticipatory ongoing palliative care continued. The patient had a peaceful end after several hours with mitigation of moral distress among family members and caregivers. So you see, you have a three-way obligation. Whenever I'm asked about end-of-life care, they talk law, as though we are creatures of law. We are creatures of ethics, professionalism. What is the evidence-based approach to the patient? If he has no curative possibility, What are you doing? That's the question you have to ask. EBM doesn't ask you to do everything all the time. There's now a statutory forced common law right to refuse treatment. There's a common law right to, common law is common sense. Now, what we know of the law, a straight answer to a straight question. Is withdrawal and withholding permissible in Indian law? Yes. I'm saying that after working with lawyers and the Indian Law Commission and various other, with the National Law School, Bengaluru, okay, with several Supreme Court lawyers and judges, having worked with them since 2006, I think, 2005 maybe, and then also as an impleader with the Common Cause judgment of 2018, as an impleader on behalf of ISCCA. So with that, and having discussed with legal luminaries, sometimes over the phone, I can say with confidence, yes. Okay. On the basis of constitutional validation and common law, the constitutional basis, Indian Constitution allows, recognizes that in certain situations you have the right to refuse. In any situation you have the right to refuse treatment. Okay? And when it applies to end of life care, you can refuse as well any life support system. So this is by common cause versus the Union of India of 2018, and also by the privacy judgment of 2017, that you have the right to autonomy and privacy when it is concerning your personal body. Okay? No state, no executive can intervene there. And then common law means by judicial precedent, you don't need another legislation to give you a right to refuse treatment. That's already there, right? You take consent. Inherent in taking consent is the right to refuse. So this is called common law or common sense. If you override somebody's refusal, you are liable to trespass. Okay, it's by law of torts. It's a civil suit. Now, criminal liability. There is no criminal liability in these situations where you have an omission to continue with life support. This does not constitute illegal omission. This is by several judgments. One of them is Airedale versus the NHS, and also by own judgments, Aruna, Shanbach, and also this common cause judgment. It does not constitute illegal omission. When something is out of your duty of care, there is a duty of care when there is the case is in a curative zone, okay, by consensus medical opinion. But there is no duty of care to give the same treatment in the end of life. So you are protected by the IPC section 92. Even if you can anticipate a death and it does happen, it is not by intent. It is actually the best interest judgment. But euthanasia, which is active euthanasia, everything is in euthanasia. By giving an lethal dose to kill a person intentionally, that is euthanasia. Medical assistance in death is allowed in many jurisdictions, but not in our midst. This is regarded as murder. Now, what is the vexed issue in law? What confuses us? When the Constitution is so very clear, there is the duty to uphold autonomy and privacy as well. The procedure prescribed by the Supreme Court unnecessarily hampers it, because the procedure prescribed by the Supreme Court was only in the context of chronic vegetative states. So they said there should be a three-tier process. One is a preliminary approval by a local body, okay, local committee. Then there is another one by the district collector, and then finally another one, physical verification by the by the judicial magistrate of the first class. Okay. Now, none of this is feasible. We have checked in many quarters. There has been no notification to this effect with any of the JMFC, okay, to any of the district collector. There is no notification by the government, so they do not know. Does it mean that our patients have to suffer a miserable death? Since the common cause, we have been continuing with our advocacy. The Indian Society of Critical Care Medicine and the Vidhi Center for Legal Policy, a think tank, a legal think tank based in Delhi and Mumbai, we have appealed, which has been accepted by the Supreme Court, for clarification, modification, simplification of procedure. Illicit is a end-of-life care in India task force formed by 3 professional bodies of Indian Society of Critical Care Medicine, ISCCM, Indian Association of Palliative Care, IAPC, and Indian Academy of Neurology, IAN. Now, these 3 bodies, of which I am a chairman, this together with Vidhi Center for Legal Policy have made a model end-of-life care guideline, which which has been submitted to the Supreme Court, and it has asked the Ministry of Health and Family Welfare to call all the stakeholders and have a discussion. Why do you think these decisions are in the spirit of the Supreme Court judgment of common cause? Supreme Court judgment confirms patients' rights. That's why they have validated advanced medical directive. So you have autonomy, but if you lose your capacity, this autonomy continues in your incapacitated state through the agency of your surrogates or appointed proxy. Okay? So you can make a document when you are with it, anticipating at some point you may lose capacity, and what you prefer, what you want to forego will have to be respected by the treating team and the family. This is what AMD means. It's about medical ethics. All laws want you to follow medical ethics. It's about weighing benefit versus harm, the best interest. Courts ask you to use the best interest argument. Decisions made collectively by a reasonable body of medical experts. They say don't take a unilateral decision. Don't take a single-handed decision. Be deliberative. Cogitate. That's the word they've used. Cogitate. Okay. Have a bunch of professionals who cogitate amongst themselves, then they cogitate with the family. Okay. So this is what medically also we are saying. What is called shared decision making model, which is most popular in the world for end of life care. This is what the courts have said in their own language. So there should be an oversight, review and conflict resolution by an independent committee within the hospital, EOLC committee. Okay. Should ideally have 5 members. The head of the institution, the director of critical care, the physician directly involved with the care of the patient, or an independent physician, okay, independent physician, and lastly, it should be a social worker or some representative of lay opinion. So these are clinical decisions made by physicians and families working together. They are not legal decisions. You can't take these decisions to the court. Unfortunately, that's what the Aruna Shanbach said, judgment said, that you take it to the High Court. This is not feasible. This is the result of a understanding between 2 parties over a period of time, building a relationship, okay, in the context of medical context. It is our responsibility which cannot be passed to the legal profession or anybody else. But we must subject ourselves to oversight, to review, to quality control. So consensus standards of care, it's also in keeping with the consensus standards of care. Our Vidhi Center and illicit guidelines, if you look up, they are heavily researched and heavily referenced, okay, more than 100 references. So you look at all of them. The references are both medical and legal. So there are worldwide position statements. Wellpicus is one of them, and there are so many societies where there is a position statement. Indian position statements of ISCCM, IAPC, Indian Association of Pediatrics. Recent publications of FICCI, Illicit, Blue Maple, ICMR and AIMS, which you are following. End of life care in India, model legal framework. So all these references I have given, you can go through them. So physicians also have rights. It's not that it's a one-way traffic. We are slavishly having to follow any family's opinion. No, not at all. You have your duties of care. So you have to see whether whether what the family has decided is okay by you or not. And we both have to come together. So there is a physician autonomy. You can't be impacted upon just by your administration's opinion. You have to see from the professional opinion. Cannot be forced to act against better judgment. This every law says. Okay, this country, other country. Patient cannot demand a treatment that is inappropriate. Okay. I got a patient who was, I mean, a vegetative state, and they wanted to do a what do you call it? Biopsy from the thalamus. I refused. Okay, but sometimes there are demands like that. Some stereotactic biopsy. Sorry, I am not obliged to do it. So it is not a, you are not giving a menu card to the patient or family and they tick something and you are obliged to do it. Not at all. You have to see, weigh, and do it in beneficence and non-beneficence. So this is a publication from ICMR. We set a task force to give you the correct scientific updated definitions on all the terms relating to end of life care. Okay, there are 25 of them. So don't bunch everything into euthanasia and get confused. Okay, they are far from euthanasia. They are in the mainstream normal medical practice in the world. Okay, they are not something spectacular or weird. So by this definition, withdrawal and withholding is this. See? So withholding is you don't start an aggressive or extraordinary treatment at all. You don't start it. Withdrawing is having started, you realize it's not going to work. Okay, it's going nowhere. You can stop. So these are ethically equivalent. You know, the Principles of Biomedical Ethics was a book written in 1982 by Beauchamp and Childress. Okay, you will be well advised to read it. It's a classic. Okay, and I think the latest edition is 2013. According to these authorities, and now most of our medical practice is based on Beauchamp, Childress, all the four principles that I named, principlistic foundation, they are from Beauchamp and Childress. Now they say they are ethically equivalent, although it's a little morally more complicated to do a withdrawal. Okay, we feel a little problematic to withdraw, but it's not illegal or unethical. Sorry, it is only a little more difficult. So the ecosystem that impacts, so the intersection of so many things in an end of life care decision. Okay, they are not in an island where just the clinician and patient exist. The institutional policy impacts on it, the institutional culture and national policy. So it is a whole community. You know, we had this Lancet Commission on the value of death. Okay. So they have gone. This is a huge, beautiful, classic document. Please go through it. It's on the net. It has brought out all the things that intersect death and dying, and it is really summarized the whole picture. Original articles and surveys from India, you can go through. The first one was by Kapadia et al. In Mumbai, then from my unit in 2009, and again from my unit in 2012. They are all single center experiences and retrospectives. And TMH experience through a personal communication, they were a little shy of publication, but I know their data. Okay, TMH also does a lot of withholding and withdrawal. And INDICAPS 1 and 2 survey, multi-center survey by ISCCM, Asian survey, CMC Vellore has published 2 articles, okay, and single center retrospective. Now, so what is the stark revelation of the INDICAPS survey? There are point prevalence surveys stretched over 4 months of ISCCM, you know, more than 4,000 cases. 10 years apart, there were 2 surveys, point prevalence surveys of various aspects of intensive care. One of them is what is happening to lama. Okay, they are called terminal discharges, but they were actually lama. Okay, 1/3 of all the deaths are going lama. This has gotten worse. 10 years ago, it was 5% of admissions. Now it's become 7.5%. So our reluctance to accept the realities of is becoming a dangerous denial. Okay, So all these people are dying without palliative care, without any compassion. And it could be us. It could be somebody known to us. Please. We all at some point end up there, and we must think what we are doing to others. That we might happen to us. So lama is a pernicious practice. It's like washing your hands off. There is no attempt to address the issues of foregoing of life support or dignity in death, only a crude attempt at escaping legal liability. It's a self-centered, not patient-centered. Okay? We have used big words of patient-centric. We ought to be using family-centric also, but we are actually self-centric in these decisions. So let us say the thing as it is, and the patient and family are left to their fate to face death without palliative care. As a widely publicized case has shown, lama is no protection against litigation. So Adya is the name of the child who died in Gurgaon. She was sent lama. After dengue, 2 weeks on, she had multiple organ failure. They said, you take the patient lama. We are not going to take any end-of-life decision. That's illegal. Okay, that's the perspective. It is a convenient perspective. It's not the actual thing. So the tube was taken off. In the ambulance, and the girl suffered a lot, and the family has sued the hospital. It's a 10 crore suit. So sending somebody lama doesn't protect you. So protection doesn't come with an unwise decision. It comes with an intelligent understanding of what is the needed and what you're doing. So time-limited trials can be given. Majority of the cases are in the gray area. It's not black and white. Okay, beneficial, non-beneficial is not a black and white, visible to us. A lot of them are in the gray area. You are not sure, family is not sure. So in an expectant manner, you continue your conversation. Okay, the fact that the evolution of the patient condition is uncertain should be brought out in our conversation, honestly. And then at some point, you arrive at a conclusion. Time limited means you give yourself a certain period. Okay, we'll see for next 3-4 days. Then at that point, when the objective is not met, by that time we have had a chance to understand from our side, a chance to accept on the other side, and come to conclusion. So foregoing of life support in the world since the 1970s, the legal and the moral and the ethical understanding and the professional practices have grown in the West. Okay, so number one in the world for end-of-life care is UK. Okay. Australia comes very high, Canada comes very high, even US comes much later, because they have really worked at it. And then legislations across the world, there are dozens of legislations now. Copious data of surveys of FLS decisions in ICU and in the community across the world is now available. Medical assistance in death is one extreme example of respect to autonomy, which is growing in the world. There are about 15, 16 countries or states in the US which are actually have legalized medical assistance in death. So Indian data is sparse, as you can see. The contribution only from Kapadia and myself. The black bar is withdrawal. Okay, we are very reluctant to withdraw, but the world isn't reluctant to withdraw. In most high-income countries, withdrawal exceeds withholding. Only Israel. Now, it is not that any religion stops you. Of course, God does everything, but we are intervening. No? These are man-made. The issues of complicated dying is man-made, not God-made. God did not originally make death so complicated. Okay, it was uncomplicated. So, if you see Ethicus study, European study has shown in the last 15 years, end-of-life decisions occupy 90% of deaths in the ICU. Okay? And there are fewer and fewer CPRs being done. And similar recent paper from South Korea says that if you measure, they had this well-dying law in 2018, and they measured the quality of death and dying, QODD, okay, by questionnaires to the caregivers. on all 20 questions relating to quality of death and dying has improved, jumped up post the well-dying law. So as the awareness grows, as the confidence in the physician grows of taking end-of-life care decisions, the quality of death and dying and family satisfaction improves. Our last end-of-life guidelines coming together to care for the dying in India, IAPC and ISCCM guidelines you must go through. It was in 2014 before the Common Cause judgment, but all that it has said has been validated by the Common Cause judgment. Let me put it that way. All is validated. So it gives an algorithm, a diagnostic flow, how you make a decision. This is updated. Federation of Indian Chambers of Commerce and Industry and illicit guidelines are available on the net. So they have updated after the Common Cause judgment. So you can see if there is an AMD, firstly you must recognize scenarios which are potentially where you can have inappropriate or excessive treatment. So there are 10 of these. You will find them on the ISSM IAPC guidelines. So for example, if you have advanced malignancy, you've gone through all the treatment, metastatic or advanced malignancy, gone through the treatment has failed, or the patient rejects any further treatment, then that is one scenario. Number two, you have catastrophic brain injury or something, okay? Either traumatic brain injury or catastrophic brain event, that's another scenario which is not reversible. Or you have a irreversible altered states of consciousness, okay, like dementia, another thing. And on top of that, you get an acute crisis. So these are some, or post-cardiac arrest, non-improvement of consciousness. Okay, you're still after 3 days, your GCS is 5 or less. So these are scenarios supported by their respective, societies. For example, the cardiac society, what they have said in given situation, or resuscitation society, given situation, what should be your next step? They are in line with all that. Or anywhere the patient or the family says, we want to consider end of life decision. Or you go by the bedside, ask yourself a question. It's called the surprise question. Would I be surprised if this patient doesn't survive in 6 months or 1 year? This is a question you can ask, qualitative question. And many times the qualitative judgment of the physician is more accurate than any of the scoring systems. So good end of life, just few more minutes for communication, because it's a communication intervention which is so important. A good end of life communication should include everything except, now open disclosure of disease prognosis of course is a must, truth telling. Allowing emotional expression of the family is highly important. That is what is therapeutic communication. Allowing family more time to speak, 50% or more time to speak is in itself therapeutic. What we are doing is we are interrupting the patient before the third sentence comes. Okay, this has been seen. We think it will take a lot of time, but actually, surveys have shown we need only about 11 minutes. Okay, we don't need half an hour or 40 minutes. If you're well trained, it will take you 11 minutes, but we are probably giving less than 5 minutes. So following family decision with minimal discussion is something not to be done, because then you are not doing your duty of care. So what has happened in modern medicine? So this was a painting in the late 19th century. Look, the patient is spending overnight with this patient of scarlet fever who is dying. Look how he's sitting. Look at the body language, the non-verbal cues are that very caring. Look at us. You're looking at the LED screen with the back to the patient. Now this is what has happened. So let us not drift away from where we started. The roots. Roots are care, patient care, excellence in patient care. That's what has brought us here. But we have cleaved to the technological development, but let go of the human motivation. So you see, one of my juniors just took this picture unawares. I'm talking directly to a patient in the ICU. It's possible. only 5%, 10% happen. You can talk, and you have to train yourself to talk in a way that doesn't disturb the patient. You have to develop the theme over a few days, but they are relieved. Surveys have shown when you enter into a conversation with the patient, their psychological pressures, anxieties, depression go down. Family anxieties and post-traumatic distress syndrome goes down. This is well documented. Right at all is the paper. Okay, if you can look at in oncology patients, in outpatient practice, what happens if you have a conversation on end of life? Okay, so these are I'm very surprised that even in that paper, only 33% on a baseline, only 33% of oncologists were having this conversation with their patients, which is very certain. Okay, so this is what you said was very true. We're not approaching this, and maybe we are talking even less in our country. So you can then talk to the family like this, sit them down. I saw, to my great happiness, there are counseling rooms in your ICU. This is the way it should be. Call as many of the family and talk. It's not just one person. Be more receptive, be more generous in your time. DNAR is not a form of euthanasia, not allowed in India, wrong, should not be documented, wrong. There is nothing in medicine which you should do surreptitiously, then it is wrong. Okay? If you do honestly, no court is going to stop you, because we are following our professional guidelines. Which court? Anyway, they are also going to ask you, what is the professional guideline you follow? That's the standard. So it's a medical intervention to be prescribed only when indicated. This is the consensus today. CPR is not a default intervention. That everybody has a right to CPR. There is no such thing as right to CPR. It's a medical intervention. It should be done if it's indicated. Nobody has a right to intubate, right? People have a right to care, but appropriate care, not mindless care. So ICMR guidelines were published in 2020. Please look through it. It's given you an algorithm how to arrive at the decision. There are institutional policies which have been published since then. Blue Maple is beautiful. Okay, it's of Manipal group of hospitals. It's a whole big publication. I had my contribution to this, in the making of this publication, and then AIMS. I've gone through this carefully. I've given my inputs to the AIMS draft policy as well. It is yet to be published, but will soon be published. Now, what is this? It's a striking picture, isn't it? There's a story behind it. This is a religious personage. He was in Vrindavan, okay, Krishna Upasak, and my patient for a long time. He was reputed to be 102 years of age. We don't know his age. So he had interstitial lung disease. I was asked to treat him 10 years before this happened, and it run its course. He had been on a PEG tube, on oxygen for many years. Then cut 10 years later, I was asked to see him again in Vrindavan, and I thought he'd run its course. I mean, there's nothing. He had a large following, hundreds of doctors of famous hospitals. So that's his family. Now the doctors wanted him to be in hospital, done everything. So we brought him to hospital, gave him pulse steroid and other things, nothing worked. So whether to intubate or not to intubate, the adopted family said, no, let us, then we had a negotiation. So it was not in favor of my value system or what I'm used to. So I talked to the family, done, sir. So we had a TMT, time limited trial, and we took him to the ashram after 48 hours, removed everything, and then he had a death which is supposed to be auspicious for people of that nature, dying in the Padmasana. Okay, so that can't be done if you have undergone rigor mortis. All right, so now this is so all this is important. Death ritual is extremely important. See, sometimes you get these beautiful letters. Mother of a famous classical, singer, legendary figure. Now, we had a withholding decision in her terminal cancer, and she died in the hospital with all the palliative care, and she has written these words from the heart. I could not find the words to thank you for the care and concern. You're so generously provided to my mother. So these are the things that motivate you. So you can see that FLS is an important decision. These decisions are complex. Quality palliative care should replace. Landmark Supreme Court judgments have allowed AMD and FLS. Procedures recommended by the SC are problematic, and efforts to simplify our own professional bodies have laid out pragmatic procedural guidelines in line with the rest of the world. Thank you. Oh, I'll just.
So thank you, Professor R.K. Mani, sir. It was a mesmerizing speech, and it was like a TED talk. We were totally, in fact, immersed into the subject. Thank you so much, sir. We will have questions during the panel discussion. Professor R.K. Mani, sir, will be available for both the panels. So with your permission, we have kept you throughout engaged, sir. Thank you. So now we will be doing a palliation program for Professor R.K. Mani, sir. जैसा आपने बताया पधारो हमारे देश, तो आपका मान सम्मान करना, अतिथि का सम्मान करना इज आवर कल्चर. So my request Professor Mani sir to please come on the stage. May I request dignitaries Professor Dr. M.L. Swarnkar sir, Dr. G.N. Saxena sir, Dr. R.C. Gupta sir, Dr. Hemant Malhotra sir, Dr. V.K. Kapoor sir also please be on the dais. सो अतिथि का सम्मान हम राजस्थानी तरीके से करेंगे. सो मैं खुशी से रिक्वेस्ट करूंगा कि प्लीज़ सर के लिए साफ़ा शॉल स्टेज पे लेके आ जाएं. मैं एम.एल. स्वर्णकार सर से और सारी डिग्निटरीज से रिक्वेस्ट करूंगा कि प्लीज़ R.K. मनी सर का सम्मान साफ़ा पहना के राजस्थानी तरीके से किया जाए. शॉल उड़ाने में सम्मान के लिए मैं सभी स्टेज पर विराजे हुए अतिथियों से निवेदन करूंगा कृपया वो भी शॉल उड़ाकर सर का सम्मान करें. डॉक्टर जी.एन. सक्सेना सर से रिक्वेस्ट करूंगा कि सर को हमारा स्मृति चिन्ह हॉस्पिटल की तरफ से भेंट करें. डॉक्टर R.C. गुप्ता सर से भी मैं रिक्वेस्ट करूंगा कि सर को एक प्लांट हमारी तरफ से पौधा भेंट करें. सर के लिए हमने एक सर्टिफिकेट भी सर हमारी इंस्टीट्यूट की तरफ से यूनिवर्सिटी की तरफ से बनवाया है. तो मैं सभी से रिक्वेस्ट करूंगा डॉक्टर M.L. स्वर्णकार सर से और बाकी सभी से कि सर को सर्टिफिकेट से नवाजा जाए. सो मंच पर उपस्थित सभी डिग्निटरीज का बहुत बहुत धन्यवाद. अभी हम अपना एजुकेशनल एक्टिविटी का पार्ट 2 स्टार्ट करेंगे. सो आप सभी से रिक्वेस्ट है कि सामने की तरफ फ्रंट रोज में आ जाएं प्लीज. हमने इसको पैनल डिस्कशन को वी हैव डिवाइडेड इनटू 2. थैंक यू सर. सो वी हैव डिवाइडेड द पैनल डिस्कशन इनटू 2 पार्ट. थैंक यू सर. थैंक यू. So may I request Dr. Nipun Lamba my co-moderator to be on the stage, please. And may I request the panelists for the panel 1, Dr. R.K. Mani, sir. Sir, please come on the dais. Thank you. Dr. Anjum Jod. Dr. Anjum is our good friend, more than 2 decades old friend of ours, and she is like Mother Teresa in the field of palliative care.
My very dear friend as well.
Yes. So she is Director of Palliative Care at Bhagwan Mahavir Cancer Hospital. Dr. Ashwin Mathur. Dr. Ashwin Mathur is a Senior Consultant, Professor in Head, Department of Palliative Care at SMS Medical College Hospital. Dr. Malhotra, sir, also please be on the dais, please, sir. You are also a panelist with the panel 1, sir. Dr. Professor V.K. Kapoor, sir. Dr. Deepesh Agrawal. Dr. Deepesh is Professor in the Department of Cardiology, and Dr. Ravi Jain from Critical Care team. So I'll request my co-moderator, Dr. Nipun, to start the panel discussion.
Good morning, everyone. Good morning, respected panelists on the dais, Dr. Hemant Malhotra, sir, Dr. Mani, sir, Anjum, ma'am, Ashwin, ma'am, V.K. Kapoor, sir, Dipesh, sir, and Dr. Ravi. My first question to Dr. V.K. Kapoor, sir, is, sir, what do you think when end-of-life care begin, and at what stage people should start thinking about that?
So we are all scientists, and we design trials and studies, and in any trial we say that there is an end point. That is the aim or the purpose or the goal which we are looking for. So I would say death is the end point of life. It is the aim, it is the purpose, it is the goal of life. We are living because we all have to die. But when do we think of end of life? The best, in my opinion, would be when you achieve a sense of fulfillment. So you have lived long, you have done enough, you have done what you wanted to do, you have enjoyed, and you feel there is nothing more to do. And I think in our mythology, there are n number of examples where people at that stage, जिसको बोलते हैं समाधि ले ली उन्होंने, there are many examples. Next would be when life becomes useless. So you may have a purpose, but because of physical, mental, or whatever deficiency or limitation, you cannot do anything, and that stage is irreversible. So that could be the end of life or a useful life. It could be when life becomes painful. When living, जो एक common होता है कि हे भगवान इससे तो अच्छा उठा ले. So that could be considered as the end of life. Or when it becomes a burden to the family, burden to the society, that one may consider as the end of life. And in all these, of course, the number, the age is important, because same thing happening at 20 years of age may not be considered the end of life, but if it is happening beyond a certain age, I don't think I can put a number on that, may be considered. And last, in all countries where there is law and order, is when your life is harmful to others. So a criminal, a terrorist, a convict, because then we are practicing legal homicide, we are killing a person, or in a war, but that is not considered as criminal activity. So I would say these are situations where one thinks life, and from today's discussion point of view, I would say when the life is painful, when it is a burden and it is useless, in my opinion, that would be the point where one should consider as if you are reaching the end of life.
Thank you so much for such a wide perspective over and when should we think of end of life care. So next question to Professor Hemant Malhotra, sir. Sir, as an oncologist, we get an opportunity several times before the patient goes to ICU or on the ventilator. So what is your thought that do we really discuss the end of life care with these patients so that we can prevent many patients from unnecessarily going on the ventilator when the disease is when the disease is so advanced that it is out of control or cure?
So I think what you're asking is very, very relevant, Lalit. And before I answer your question, also like to tell everybody that this is your opportunity to ask Dr. Mani any questions or any clarifications you have about his truly wonderful talk. Now, coming to your question, I think, I am equally guilty on that front. We do not speak to patients regarding ICU admissions, the futility of ICU admissions, and the other aspects related to terminal care as much as we should. In fact, there is a peculiar situation in our country. There is, I may be wrong on the percentage, but there are at least 50% of patients or families with cancer. Before the patient comes into your room, 2 or 3 attendants barge in and they say कि सर उनकी बहुत कमज़ोर हैं वो, आप उनको कैंसर का डायग्नोसिस और प्रोग्नोसिस मत बताना, उनको बोल देना सब कुछ अच्छा हो जाएगा. And unfortunately, some of us, 100% because of compassion to the family and the patients, we don't talk to the patient about his or her disease and the prognosis. So we are way, away from talking about ICU hospitalizations, about futility of aggressive interventions, and about DNR and about stopping terminal care. So we have to first have that much faith in our patients, directly in the patients, to be able to talk to them about the disease, to be able to talk to them about the prognosis, and give them time to decide as to how they want to take the terminal care forward. So a huge amount of barriers need to be removed, and a huge amount of communication needs to happen. Now, who does that? Whether we do it as clinicians, as practicing oncologists, or our palliative care team does that, or our critical care team does that. I think all the three together, especially the treating oncologists, they need to talk to the patient about all this upfront and to every single patient.
Thank you very much, sir, for your inputs. My next question is for Dr. Ashwin Mathur ma'am. मैम एक बहुत बड़ा कंफ्यूजन रहता है कि लोग पैलिएटिव केयर को हॉस्पाइस केयर के साथ कंफ्यूज करते हैं. सो व्हाट इज द डिफरेंस बिटवीन पैलिएटिव केयर एंड हॉस्पाइस केयर? और मैम आप क्या सोचते हैं, वेयर डू इंडिया स्टैंड्स इन टर्म्स ऑफ हॉस्पाइस केयर एंड पैलिएटिव केयर?
See, to give comfort care, to give relief, to increase quality of life, or to improve on quality of life, palliative care services and hospice care both do it. But the basic difference here is that palliative care, hospice care is usually prescribed to a person who the treating physician believes or thinks that has a span of around 6 months if the disease is allowed to take its own course. So the definitive treatment for an illness is not given in hospice. Whereas if you are taking palliative care, you may agree to be taking the curative treatment too. So the basic difference here is the span of life, expected life, and whether the patient is willing or is a candidate for definitive curative treatment, which is there in palliative care but not in hospice care. So hospice care is usually the end of life care sort of a thing, where we feel that the lifespan would be around 6 months or so, and the patient is not a candidate for definitive treatment. In India, like the second part of the question, I feel we still have a long way to go for quality hospice care. Another one reason I feel, these are my personal views, of course, that why we are not been able to develop hospice care sufficiently, because our socio-cultural fabric is such that we still have the family with us. So we are, in a way, we are providing end of life care in a family setting. But now with the things changing, with more people staying alone, with children being away from their parents, parents staying alone, old age people staying alone. So probably now we will be in a position, and we need to have more hospice care facilities. But we still have some way to go till we have quality hospice care setups.
Thank you. Thank you so much, Dr. Ashwin. Dr. Deepesh, as a cardiologist, you see many young patients coming to you with MI and in terminal phase of life also. We know that we can write our advanced directives or living will. This has been discussed various times. So what are your thoughts on that?
Yes, I think end of life care, what we have discussed till now, is basically to prepare ourselves when we reach at a certain stage where we cannot decide. But for me, if you talk about cardiology perspective, so in cardiology, many a times we don't have much time, except for few illnesses like chronic heart failure or multivalvular disease, where the patient are on life support system for a quite longer time. So for that, I hope each of us should have our will and directives. What if any stage reaches at that point of time where we are not able to take a decision, how long we should keep on that supportive system, when we should stop it. So probably we should make a will. Personally, if you talk about myself, before this session or before this talk, I was not much aware of this thing. So I personally thank you all for this, to make me aware of this kind of thing. And probably what Srishti has shown the data before that, they also said the number of persons sitting over here, they are less than 50% those who know about it and they think about this talk. So if a person is having chronic diseases where he is not able to take a decision and they are on prolonged life support, and if we think that is futile, then definitely we should take a decision. Our family member or loved one, we should take a decision to where to stop, where not to go beyond the therapy. This should be given in written prior to, when we are in good health, mental health as well as social health, with the help of our family members, our loved one, or whoever is near us. Thank you.
Dr. Malhotra sir has a comment to this living will issue.
So I think Deepesh is very, very correct. Before we start thinking of the patients, let's think of ourselves first. And I'd like to ask Dr. Mani, sir, is it possible for me to make a do not resuscitate document at home in the presence of my family, and they sign? Will this have any legal weight? Will Dr. Shrishti or Dr. Ashish give it any weightage? Or do I have to go to court and get it registered in the court for them to be sure, okay, this is a valid legal document, I will not CPR this gentleman?
You see, what the court has said is Advanced Medical Directive, or AMD, is a legally valid document. One can make it at any stage of life. Okay. Generally, we do it when we are anticipating trouble. But it can be because one can have a difficult situation quite suddenly also, like the Superman had, Christopher Reeve, or somebody else recently. Okay, the racer. Okay, they suddenly had it, and they have got, people can get into a vegetative state. So you can make any time. Now, by our code, you're supposed to have it to make it a legal instrument. You would have to have 2 witnesses and validated by the judicial magistrate of the first class. But medically speaking, we are not just looking at the legality. We want to know what the patient wanted when the patient was in full capacity. So if something written is given to us, see why the court wants a legal validity is they suspect everybody. they suspect foul play by the family. They might try to do you in. That sort of they come from that angle. But we are seeing families every day. Such families are very rare. Who want to really do you in? The families are suffering. So I would respect whatever is given to me as a patient statement. But as of now, legal validity as a legal instrument, you would have to go by what the court says. We have in our clarification and modification appeal have brought this out, that lot of elderly are not able to go and get all this paperwork done. Okay, so any two witnesses are enough. All over the world, witnesses are. You don't have to get countersigned by anybody, and or notarize. Okay, going to a magistrate may not be possible for most people, particularly in the interiors. You have to go to a big city, but notarization will be possible. We have given also, like your estate will. Okay, estate will doesn't need a magistrate. It can be notarized. So we have discussed with the legal experts and given also alternatives. Government has to read on that, respond. I want to say, is there anybody else? I just want to have a few words about the preceding discussion. They were very interesting. I think it was mentioned when do we sort of face an end-of-life situation. Of course, there are life's end-of-life situations. You have a fruition, you have completion, or you are sick with life. All those things are wonderful. This brings out the humanity in the whole thing. Medically speaking, from the medical perspective, we have identified about 10 scenarios. The 10 scenarios, I mentioned one or two. Now, the frailty and old age in itself is not. Frailty and old age combined with anything else, or with a living will or something, those are also one. Any organ failure, irretrievable organ failure, be it lung, liver, heart, or in the terms of brain, atrophy and dementia, when they turn up in the end with a terminal event, that is also a scenario which should trigger this conversation. Or it should trigger a conversation much before they enter an ICU, which is called advanced care planning. Okay, you have this, you can enter into a scenario which might make you go to the hospital. Don't go. Okay, you don't need to go. You have an option to, because the ideal good death is what? Right, home, amongst the loved ones, not being medicalized, being more spiritualized rather. So, that is, from that perspective, we have seen that whenever there is ACP, advanced care planning, lot of people end up executing an instrument like a living will, and also eschewing going to a hospital or ICU, or also execute a DNAR, WD, WH decisions.
Thank you very much, sir, for your enlightening thoughts. My next question is to Anjum ma'am. Ma'am, you are practicing palliative care for such a long time. Please हमें guide कीजिए that why we are afraid to tell the patient and family about death, और वो क्या barriers हैं which are preventing us from delivering end of life care.
Thank you, Nipun. Very important question. I think all the panelists have spoken about it to some extent. Dr. Hemant actually began with the right step, that collusion, because many of our patients don't know that they have cancer or an advanced illness. I'm working in a cancer hospital. So like Dr. Hemant said, many patients don't know. And so beginning with that, ignorance is difficult. Then families also have a lot of social stress. The son might feel that my sisters want further care. They might have pressure from the society that the son didn't want to spend money on ICU care and they brought the patient back home. From our healthcare providers' perspective, what Shrishti said in the morning, that 77% of our respondents didn't know how to talk to patients about end of life, didn't know how to start the conversation, didn't know how to break bad news. That's our mistake, I guess. But I think the NMC has started the 8-com module. So our teaching is not ethically grounded. We're not teaching our students ethics. We're not teaching our students how to talk. And as a result of that, we as healthcare providers are falling short in our duties. We can see phone calls from a resident saying that, ma'am, family care is sab kuch karna hai. So what did you ask the family? We asked the family, sab kuch karna hai kya? So is that the right question we are asking? Are we asking the right question? Sab kuch karna hai? So we are asking the wrong question to the family. The caregiver will say sab kuch karna hai. So we need to ask exactly what this intervention will result in this effect, and what do we want to do? So the questions you're phrasing to our families are wrong. Then the environment. So I know hospitals where you have empaneled, if the army is paying, if the central government is paying, if ECHS is paying, the family is keen to continue all kinds of care. If there is 0.002% chances of care, of response also. So that is another big barrier. Because when somehow with all kinds of familial ties also, if the patient's family pays for it, somehow they get more empathetic and sympathetic. I'm sorry to say that, but a lot of empaneled patients are difficult to talk to about withdrawing support.
Thank you. So anybody from the audience wants to add on to this discussion?
One second. I 100% agree what Anjum is saying. I think about 9 out of 10 patients who have some kind of CGHS beneficiaries or armed forces beneficiaries whose ICU care is being paid for, and I don't know whether our intensivists will support. I agree or not. They say कि नहीं ventilator नहीं हटाना, कोई बात नहीं, चलने दो. And if you're paying out of your pocket, then you talk about stop resuscitation and where are we going, which is unfortunate but true.
So Professor Purvish Parikh sir has one point.
Deciding
Sir, before you start, let me introduce sir, because many of you don't know him. Sir has been professor and head in the Department of Medical Oncology at Tata Memorial Hospital, Mumbai. And sir has recently joined with us as professor and head, Department of Hematology. Thank you so much, sir. Please go ahead, sir.
So I'm going to share one story.
Yes, sir.
Which is a real life story of what happened to one of my patients. Okay. Patient was having lung cancer with brain metastasis. He was treated with 4 lines of therapy, and ultimately he was in a ICU ventilator. Okay. So according to whatever has been discussed so far, this patient is end of life and we should decide about withdrawal of support or not. At that point, it was my colleague's patient, and at that point I was consulted. And incidentally, the molecular diagnostic test that was done found that he had an exon 20 insertion mutation, which is very common, which is very rare in lung cancer, but it responds very well to a specific therapy. We started the therapy, 3 days later he woke up, and 10 days later he went home walking. So we cannot play gods. Just because a group of 5 doctors who are specialists feel that this patient is end of life, are we actually denying the right of life to the patient? I think we should keep that in mind.
That is very, very valid point. Dr. Anjum.
So one point that Dr. Purvish really brought to the front is that there are gray areas, and there is definitely diagnostic or prognostic uncertainty. In cancer, phir bhi there is some definition. In non-cancer, dementia and Alzheimer's and Parkinsonism, neurology, very, very big gray areas, very difficult to prognosticate.
So I think in the interest of time, we can discuss in the next panel. We have another back-to-back panel. Yes, madam.
See, there is not a rule to withdraw or not to withdraw. There is an option. So we have to discuss options. As Anjum said, should we do everything? You ask a question, a leading question like that. They say, yes, do everything. But we haven't opened the question, what are the options? Okay. What does doing everything mean? Now, to one person, it may mean doing everything means doing everything in palliative care to ensure comfort. And Dr. Parikh said that there was one case where you could make a change. This uncertainty is always there, sir, but it is not universal. What I'm saying is, for every case like this, there are scores of cases which are getting excessive treatment. This is the experience collectively throughout the world. Okay? This is not a one-off. That is why we have to ensure at the outset, our flow charts say there has to be an iterative, there should be a deliberate and iterative diagnosis and prognosis. You have to go back and forth. somebody says there is an option, having explored all the options, okay, you had not done the molecular testing before, then you did the molecular testing, so that option was there. So having explored the curative options, if you come at a point, then see, nobody can play God, but we are playing God whenever we are intervening also. All these are artificial supports. We must remember that God didn't create this kind of death that humankind is created today. Okay, originally, in the 1950s, we had all these advances in medicine causing artificial supports and intervention. Before that, there was nothing. So that sort of argument may lead to an excessive treatment all around. And most of our ICUs will be filled with people with vegetative state or dementias or end stage on, and those people who are in the curative zone may be denied those access. So we have to, while we accept that there is an area of uncertainty, we also need to be pragmatic. And why do they say you must have a collegiate decision making? It's just because of this. There might be a possibility of some paradigm shift in our treatment which has to be explored properly. That can only come with discussion.
Thank you very much, sir. My next question is to Dr. Ravi Jain. Sir, you are our critical care specialist. You are working in our institute for a long time, and our institute is one of the major centers for organ transplant, whether it's kidney or liver transplant or heart transplant. Sir, what do you suggest? हम कैसे discuss करें? How to discuss organ donation with patient and family when the time comes?
Speaking of organ donation, is completely entirely a separate thing from the today's theme. Okay, so it is completely different genre than the today's topic. End of life care is something when the patient is terminally sick, and end of life care when the patient is otherwise okay and brain dead. What we are, I'm sensing that you are asking. So in all the communications, basically, how like how to discuss organ donation, all the communications, basically, I prefer that we follow strict spikes protocol, setting up properly, talk with the family, with knowing their perception and values, and being on the same page is very important before initiating any kind of this kind of sensitive conversations with the family. But before breaking such bad news or talking about organ donation, all the treating team, all the panel of team, and all the ancillary staff, nursing staff has to be on the same page that the patient is not having any chance. Then only we initiate this kind of sensitive discussion. And before talking about organ donation, we have to be doubly sure that the patient is having no hope and is certainly a brain dead patient. Then only we start discussions about organ donation.
Sir, please.
So I have another question to Dr. Mani, which I think reflects the sentiment of quite a lot of people in this audience. Sir, we go back to your scenario 2, that elderly gentleman, bureaucratic background, on a ventilator, tracheostomy, not being able to be weaned off, but in fully conscious, able to communicate through writing. It is, much less complicated in that patient, because that patient himself is giving a document to you which is saying, it could be video or it could be a text document, which is communicating to the caring team that I don't want ventilation to continue. I'm fine to be, not resuscitated. Now, in another situation, if the patient doesn't have like a living will, and the patient is not in a position mentally or physically to decide whether to continue or not, and the family is telling you either to continue or to not continue scenario, are you legally protected if you listen to the family, not listen to the patient? And another situation is where 2 members of the family are saying stop the intervention, and one member of the saying, please don't stop, continue till asystole. How do you go about that? How do you, make sure that if you follow advice of these two people, they won't take you, the other person won't take you to court and vice versa?
Yeah, this is the crux, So the last case was when the patient was not having capacity. No, the second case I had capacity, so that is relatively easier. But the last case I showed you, that person, the religious personage, there everybody took on behalf of the patient. If you have a split, then wait. All our guidelines say that drive a consensus. All our guidelines, ISSM guidelines, FICCI illicit guideline, AIMS guideline, they say have a negotiation. You have to navigate. These are the sort of words they use. You navigate, you call for repeated meetings. If you have not resolved, then have a TMT, that is time limited trial, TLT, which is what we did with the last case. Time limited trial, by which time people get to know, what we are speaking is actually, that's how it's all panning out. Then we get a consent. Now, as far as the legal thing is concerned, the common cause is clearly listed these three scenarios. Okay, one that is directly from the patient, then there is no question. Okay, easy. Number two, you have an AMD. Again, it's easy. But if you don't have an AMD, same procedure. You can take a decision on behalf of the patient with the shared decision making model. That's what they said. You cogitate. A group of physicians and a group of family. Now, you may have some family member not agreeing, then you do have a loose hierarchy of importance. This hierarchy is not spelt out in law, but it exists in your organ donation. Go on. Okay. The most important person is your spouse, children, siblings, grandparents, grandchildren, something like that. So you then, the opinion of the wife or the husband then counts for maximum. But as far as possible, see, I have maybe hundreds or thousands of these cases I have negotiated and done. I have not got into any legal problems so far. God bless. Okay, touch wood. But then the thing is, this is what we pragmatically, this is what we do. We call most family. Now, if there is some member in California, we do speak. We do. The daughter from syndrome, you do talk to them. Nowadays, you can talk to them on the phone or on a platform, digital platform. You talk to them. By and large, you may have outliers. Okay, you may have outliers for everything. As Dr. Parikh pointed out. Even after real deliberation, you may go wrong. Yes, we can go wrong. But by and large, you will be right. What happens is, if in case, in spite of your trying, you cannot resolve these questions, you come into a conflict, you may ask a third person to come in, okay? Or your hospital ethics committee or EOLC committee can come in. Or you can have a psychologist. Some people have a difficulty in accepting death, particularly in oncology. They have difficulty in accepting death, then you can talk to them. Or if a family has difficulty in accepting death, you can talk to them. So these are therapeutic opportunities, all right, which we must seize, and then the decision making can be. If you can't do, don't take them. Those people who are willing to take this option, you give it to them. If not willing, there is no obligation to force.
So I think with this, yes, sir.
On a critically ill patient, and they have agreed upon. Then what is the way? Say, then is the DNRA is allowed, or what you called a one term de-escalation? That is how.
Once you have agreed, and the physician group is also of the same opinion, you implement, which I showed you in the examples. We implemented.
That how you implement? You can immediately or gradually withdraw the drugs.
No. Yeah, there are three things. Non-escalation is one. De-escalation is another. Withdrawal is another. Or withholding, not starting at all. All these are options. You have to customize to the patient and the family and everything.
For that also you have to take the consent and
You have
everything.
to. Everything has to be documented. There's nothing to be done surreptitiously. I have not taken a single decision surreptitiously. That's why I'm confident. I never had a loss of sleep over this.
Thank you.
Just a very quick question for someone. It's been a really fascinating couple of hours that we have spent. You have talked of situations where somebody wants, somebody doesn't want. It's not uncommon in our scenario that the patient and their family trust you, and quite often the doctor is dumped with the decision of withholding treatment or withdrawing treatment or going on life support. आप जो समझते हैं ठीक सबसे अच्छा मेरे मरीज के लिए वो आप करिए, आप decide कीजिए. How do you handle this situation?
You see, autonomy means respecting the patient's, agency. But if the patient says, no, you decide for me, or my uncle will decide for me, that's also respecting autonomy. I cannot force the patient to decide for himself. Okay? His decision for himself is for you to take charge. Then you accept it with humility and then do the right things, okay, in patient's interest, best interest.
So, sir, we have one more panel discussion. Professor Mani will be available, sir. She is looking very, very on.
Give me the sound. I am Dr. V.K. Jain, Professor Emeritus in Pulmonary Medicine Department of in this institution. Before that, I worked in government also, and also last 10 years I was here as a professor at. Excellent, congratulations, Dr. Mani, for wonderful, excellent lectures and all the comments by the other panelists. Most of the issues have been discussed related to medical, social, ethical, legal, palliative care, hospice care. Wonderful day. So one of my suggestions, which I have also had an opportunity to have a panel discussion on end of life and religious rituals and traditions. That is also a part of issues. At the end of life, when the patient is admitted either in the hospital, either in the ICU or ward, and the patient at the stage of end of life, many times the relatives, they are coming. कि सर हम इनको पूजा करेंगे, मंत्र पढ़ेंगे, हम इनको पानी डालेंगे, गंगा जल डालेंगे. There are different rituals in different religions. Christians.
So we are a little short of time. Can you ask a question quickly, please?
That issue has to be discussed, and the training has to be given to the residents also, because many times they say no, नहीं करने देंगे हम ICU में, आप बाहर जाइए. So there will be a problem there. So we have to also train this religious matter while we are tackling and managing this problem. That is my comments,
Would you like to comment
has to
on
be
that,
added.
You see, you asked a very sensitive, very, very important question, sir. We allow non-obtrusive religious rites, okay, when it happens. 2 or 3 things we do. Okay, all the unnecessary tests, even the monitoring and all the sounds and all that, we take off. We allow free visitation to the patient. Free visitation, because that's what improves the quality of dying, to be with the family. Allow religious people, his guru or somebody to come. Okay? Religious rites. Most people want some chanting going. Okay, Om Namah Shivaya. Very good. System for dying is our responsibility. And if the patient or the family asks for it, we should make that happen as far as possible. It can't be a loud thing. Non-intrusive, obviously. Non-intrusive. And if it disturbs the ICU and all that, move the patient to a more where there is more privacy. Okay, these are all the decision making around, this sensitivity.
Thank you so much. I'm really thankful to our panelists for the panel discussion 1. I would now like to invite our panelists for the second panel discussion. Dr. Mani would be our expert in this panel discussion as well. So I would like to invite Dr. Purvish Parekh sir on the dais. Dr. Purvish Parekh is our head of the hematology in Mahatma Gandhi Hospital. I would like to invite Dr. Vivek Saraswat sir. He's the head of hepatology in department. I would like to invite Dr. Sudha Sarna ma'am, head of palliative care medicine in our university. Dr. Ashish Jain sir, director of critical care at Mahatma Gandhi Hospital. Dr. Mukesh Sarna sir, he's our professor in Department of Medicine. Dr. Gaurav Goyal, our neurologist in the Department of Neurology. So, thank you so much, sir. In the restraints of the time, we will start this panel discussion right away. So the backdrop is coming. Wait for 10 seconds. So my first question is to Dr. R.K. Mani, sir. Sir, you were a part of Aruna Shanbach case that happened some years ago, and very close to me because I've seen her myself. I'm a student of KM Hospital, and that's why I wanted to ask this question to you, that how Aruna Shanbach became the symbol of controversy in India. Do you think Pinky Virani was right using the Article 32?
You see, Pinky Virani had the heart, but I think she was not well informed as to the medical provisions. Okay. She asked for euthanasia. See, there are medical provisions which are not euthanasia, right? So my frustration was when we were part of a panel invited by NDTV, that she, I think, would have been more effective if she had consulted the medical side who are informed about these. So what we needed to do with Aruna Shanbach, unfortunately, as a system, as a society, as a country, we didn't do right by her. 40 long years, she was in a vegetative state, and we thought, I am looking after. You know, the nurses of Bombay Hospital said, KM said, we are looking after, we are sacrificing, okay, she's ours. We did not imagine or put ourselves in her shoes and say, what would I experience in her shoes? Okay. What would I experience? We did not ask that question. What are the patient's rights? It's not just about pro-life or anti-life. It is about, this is a situation, right? It's not a pro-life issue. It's not a putting somebody to death issue. It is whether any interventions on her, you know, what she would have wanted. There are similar cases like many in the world, and they've all, most of them, the court has allowed removal of artificial nutrition, which was the question in her case, which was not addressed properly.
True.
Okay. Number two, when she actually had deterioration, she died on a ventilator.
Yeah.
At least that could have been avoided. So I think the discussion was around euthanasia. So it was a digression from patients' rights and what medically could be done for her. Okay, it is not taking away somebody's right to live. It's taking away somebody's right of agency of how I should be treated in a situation like this. We never addressed that. So
True.
It was a missed opportunity.
So as I would understand is that there was a lack of best practice decision from the Department of Medicine, KM Hospital, who were looking after her, rather than Pinky Virani being questioned. Yes, ma'am.
suddenly on one day, he's opened his eye, and that is of more than 20 years. I myself is a witness, and he's still alive and walking. So sometimes certain cases are there which make you, whenever your loved one is there, to which make you back to take such decisions to withdraw. There are I have 2-3 cases, but this is one of the case, and everyone started telling her Savitri Satyavan ki kahani. So rarely we come across such things. Then no, but that's true.
See, the issue is that there are cases where you have these outliers when you can be wrong. Human beings can be wrong. Now, see, deceased donation is only possible after the dead donor rule. Only possible after the dead donor rule. Now, brain death, if you take the absolute definition of brain death, okay, there should be no sign of any cellular activity. That you can't judge. That means we can't take even a decision on a brain death by whatever criteria we are using. See, medicine has evolved certain criteria for brain death. And if you apply those criteria, maybe such cases where people will wake up like a Rip Van Winkle will be extremely rare. So we take a pragmatic consensus decision, right? Now the brain death project, which was published recently, a publication of I think 35-40 countries, neurologists from 35-40 countries, or a neurointensivist. So they have accepted the present brain death criteria as death. Otherwise you can't have any organ donation program. If you take a view that some people may just wake up. We have some scientific criteria, like if you follow these criteria in a large body of people, how many people wake up like this? You know, there are data. You have data. For all this you have data. If it is 0.001%, then it is obviously, there is no absoluteness of this rule, but there is a pragmatic middle ground where you can have a consensus based on certain criteria. So you see, this is as far human mind can go. Whenever withdrawal decisions are taken or withholding decisions are taken, how many people don't die? Okay, that's another survey. Yeah. Okay, you've taken a withholding decision thinking a person will die. 4.5% of people don't die. But the situation where they were in, the appropriate management was not to intervene. So you have to take it from there. So the issue is, and then you have the final thing. If the family is not comfortable, you don't coerce them into this. No coercion. You are not going to impose your opinions or your biases or your values. You are going to allow an option to be explored by the family. There is a whole body of people, whole body of professionals. There are surveys, you know. So that is why you have to take the both together. See them both together.
I would request my audiences to please keep their questions for the end. Let us finish the panel discussion first. My next question is to Dr. Ashish Jain. He is the Director of our Critical Care Services. He also belongs to the Jain community. So there was a question about the religion. Dr. Ashish, you must be remembering that Supreme Court had rejected the Rajasthan High Court judgment directing Santhara or Sallekhna, which is the Jain way of fasting to death, to be treated as a suicide. हमारे पूरे जैन समाज ने पूरे 15 दिन जब तक कोई सुप्रीम कोर्ट का रिजल्ट नहीं आया, सड़कों पर बहुत नारेबाजी की. आपको क्या लगता है, संलेखना सही है या गलत? और अगर आप इस सिचुएशन में होंगे तो क्या आप अपने लिए संलेखना का चयन करेंगे?
So it's a bit religious question. Yes, I very clearly remember that in 2015 when this happened, a plea was filed in Jodhpur High Court by some Nikhil Soni for against his grandmother who took Sanlekhna. And संलेखना लेते ही क्या होता है ना कि वो एकदम से डेकोरेटिव फैमिली हो जाती है और वो जो व्यक्ति संलेखना लेता है उसको एज ए प्रीस्ट, ऐसे साधु और बहुत बड़ा आदमी बना के पूरा समाज वहाँ पे ना इकट्ठा होकर उसको ग्लोरीफाई करने लगता है. सो ही fill this petition in Jodhpur High Court that it is a kind of suicide as well as it is a kind of sati pratha. You are glorifying a death. And our High Court, Rajasthan High Court, gave a decision stating ban on संलेखना, which was by Jain Samaj बहुत ज़्यादा repulsion हुआ, उसके बाद Supreme Court ने उसको lift कर दिया, ban हटा दिया. So what actually संलेखना is, we need to understand. अगर मैं religious point से बोलूँ तो संलेखना means जैन साधना का प्राण है संलेखना. अगर आप जैन साधु हो, हम मंदिर जाते हैं, अपने मंदिर जाते हैं, आप भी जैन हैं, है ना? तो हम वहाँ क्या डिज़ायर करते हैं कि जब हमारी मृत्यु हो तो वो साधना के दौरान भगवान को याद करते हुए हो, ईश्वर का स्मरण करते हुए हो, उसको हम कोशिश करते हैं कि ऐसा हमारे साथ. ठीक है, तो संलेखना का मतलब होता है सत धन लेखना. लिटरल वर्ड में होता है कि आपकी जो इच्छाएं हैं उनको धीरे धीरे आपको अपने दिमाग से, अपनी आत्मा से, अपने शरीर से हटाते जाना है, अपनी इच्छाओं को कम करना है और अपनी आत्मा की शुद्धि की तरफ आगे बढ़ना है. संलेखना 1 मिनट में नहीं होती. कोर्ट पिटिशन में कहा गया कि आत्महत्या है. आत्महत्या एक मोमेंट पे होती है. आदमी कभी भी कर सकता है, किसी भी एक क्षणिक आवेश में आया, बदले की भावना आई, गुस्सा आया और उसने फांसी लगा ली. दुख किसे हुआ? आदमी के अपने शरीर को खत्म करना उसके पीछे उद्देश्य है, या किसी दूसरे की लाइफ खराब करना उद्देश्य है. उसका उद्देश्य खुद की आत्मा की शांति या उसका कहते हैं प्रमोशन नहीं है. संलेखना बिल्कुल अपोजिट होता है. और अगर मैं हमारे आज जो हमारा टॉपिक ऑफ डिस्कशन है, लेट्स टॉक अबाउट दैट, तो आई एम सरप्राइज, मैं इसके बारे में सोच रहा हूँ अभी जो, तो मुझे सर की बातें सुन के ऐसे याद आ रहा था कि हमारे धर्म ग्रंथों में तो डाइंग विद डिग्निटी हजारों सालों से. चंद्रगुप्त मौर्य ने संलेखना ली थी, बिंदुसार ने संलेखना ली थी, हजारों साधु संलेखना ले चुके हैं. तो जैसे फर्स्ट चीज़ होती है कि संलेखना हम किसको देते हैं. आज हमारे मॉडर्न डे प्रैक्टिस में जब हम किसी पेशेंट को पैलिएटिव केयर के लिए काउंसिल करते हैं तो हम पहले पेशेंट का केस स्टडी देखते हैं, पहले पेशेंट की हिस्ट्री देखते हैं कि वो ट्रीटेबल है भी या नहीं है. इसी तरह से संलेखना में आप ऐसी संलेखना नहीं लेते, आपको संलेखना साधु देता है. कोई महाराज, कोई बड़ा व्यक्ति जिसमें इतनी क्षमता हो, जो आपके पूरा बैकग्राउंड चेक करे, आपकी केस हिस्ट्री चेक करे, आपको असेस करे, उसके बाद कहे कि हाँ ये व्यक्ति उपयुक्त है. तो हर व्यक्ति संलेखना नहीं ले सकता. दूसरा, जब हम पैलिएटिव केयर की बात करते हैं तो कितने समय के लिए देना है. संलेखना का जनरली टाइम होता है 12 साल. आपको 12 साल तक करना है. आपने कहा फास्टिंग टू डेथ, इट इज नॉट लाइक फास्टिंग टू डेथ. आप किसी की खाना बंद नहीं कर रहे हो, आप उसके खाना या आप उसकी इच्छाएं, जो भी कषाएं हैं, उनको कम कर रहे हो. और वो कम कर रहे हो 12 साल में जाके. अगर आपकी बॉडी रिकवर हो जाती है, आप उसको छोड़ दीजिए, कम टू नॉर्मल लाइफ. ये भी उसमें प्रावधान दिया हुआ है. तीसरी चीज, जब हम बात करते हैं कि इसका उद्देश्य क्या है, पैलिएटिव केयर का उद्देश्य होता है कि बॉडी शांति से पेशेंट एक्सपायर हो जाए, उसको कोई पेन ना हो. संलेखना भी ये कहती है कि आपकी बॉडी लिबरेट होते समय आप शांति में है, क्योंकि आत्मा अजर अमर है जो सर ने कहा, और बॉडी है जो चेंज हो जाएगा. तो हमारे धर्मशास्त्रों में तो हजारों सालों से संलेखना है. सो आई थिंक इट इज़ ए गुड थिंग. अगर मुझे ऐसा मौका मिला, मुझे लगा है, पता है कि आई एम नॉट दैट काइंड ऑफ पर्सन, बट यस, I would like to die like this. Right. In that last moment, I would like to die at my home. Why should I be admitting in the ICU on a ventilator? I don't like this.
Thank you so much, Dr. Ashish. My next question is to Dr. Mukesh Sarna, sir. And we had been discussing this. Sir, we listened to everything. And till now, we are still confused that are there any formal guidelines for end-of-life care which safeguard us against the lawsuits? After this discussion, do you feel safe? क्या मुझ पे कोई केस नहीं करेगा अगर मैं एंड ऑफ लाइफ केयर की किसी से बात करूंगा तो?
And the very simple answer to this question is partly yes and partly no. So there is no simple question for this answer for this question. Reason being, after we discussed about
this law and safeguarding us. I've gone through so many guidelines and the videos and SIRS guidelines and videos available on YouTube. And after reading all the guidelines and laws, मेरे दिमाग में एक ही बात आई कि वो बड़ा हुआ तो क्या हुआ जैसे पेड़ खजूर, पंछी को छाया नहीं फल लागत अति दूर. Because these laws are there, but they are not going to help us when we need them or a patient needs them. You know, in a TV show I was watching that there will be now a queue for asking for death, because if this advanced medical directive is there, then I have to go to a magistrate to authorize that this is correct, and then the hospital will form a team of 3 doctors of 20 years of seniority. Then they will give the report to collector. Then collector will form a committee of 3 doctors with CMO as head, and that they will give the report to the magistrate, and then magistrate will go to the hospital, and then hospital, there he will decide. And if anywhere it is no, then the family can go to the high court, then divisional bench will be formed, then they will form a medical team. So, you know, by that time patient is not alive. So we are practically allowing, the court is allowing, but denying the justice. Delay is denying the justice. So to safeguard us, what I think we should follow is our societal guidelines and our Apex Institute's guidelines. So we can safeguard us that this is the standard practice. We are just establishing that continuing the medical treatment is futile now. We are coming on the same page and same platform amongst us in the caregivers. We are taking the opinion of an independent physician. Now we are discussing with the family, and we like that family should also come on a same platform, on same page. And then after discussing the modalities, now we are going ahead, we are signing all sort of checklist and then the forms and all those things and safeguarding us. So in my view, there is no law which can short give you a safeguard when I practice intensive care. Thank you.
Right. Dr. Mani, would you like to add something to this?
See, this Sandhya is very interesting because, you know, one thing is, of course, a religious practice hallowed by tradition. Okay, and to what extent we are interfering with that. It's not only the Jain Munis, you know, it is all, Vivekananda died, just sat in meditation and then gave up his life. So that is the tradition of so many of our rishis and munis. Now, issue is, being equated to suicide is a major problem. Suicide laws themselves are antiquated. Okay? No, antiquated, and they are perhaps belong to the 19th century, because most of the advanced countries have thrown away this suicide laws. Okay? Because of autonomy. On the one hand, you say autonomy is an inalienable right. Okay? Your privacy is inalienable. These are the two judgments. Now, how does the state come and tell me whether to eat or not to eat? It doesn't make sense.
Sir,
okay?
Dr. Sarna doesn't feel safe. He thinks that the law is not supporting him if there's a problem. But on the contrary, you feel safe. So who is right and who is wrong? How do we come on the same page?
We can both be right, you see. We can both be right. I'm quite comfortable with that. You know, I think Dr. Sarna is absolutely right. See, the law does not protect us because the law doesn't know what it is talking about. It is only talking about PVC, okay, permanent vegetative state, PVS, and so it thinks that it's like any other litigation. It can drag on for 10 years, and after your death, the decision will come. So you know, it doesn't know. It only knows what you put in. Okay? Data in, data out. You haven't given it any context, nothing. So every medical context cannot be covered by law. It can only give you the principle. And I told you the principle is valid, that you can refuse life support. Withdrawal, withhold treatment are in principle absolutely valid. In practice, because the court does not know the context, it knows only PVS, We have to tell the court these are the medical contexts. If I should be called to court for one of my cases, okay, I would welcome it. On the one hand, I said, touch wood, I have not been, but I would welcome it if they call. It gives me an opportunity to tell them what they don't know. So let us understand, there is no law which can protect you from litigation, but there are laws and your medical practices which can be your robust defense. Is there any guarantee that in non-end of life decisions you won't be called to court? Keeping a patient on a ventilator in spite of brain death has given an adverse suit. This was in Delhi. A 14-year-old boy was brain dead, and there was a suit against the hospital that they kept the body just on a ventilator to make money, and it went against the hospital. They've had to pay a penalty. So what I'm saying is there's the other side of the coin. If you think you're not going to take any such decision and you will be protected by the law, not at all. Where there's some good lawyer or somebody can point out where there is an error of omission or neglect or not following the medical norms, you can still be called to question. So what I'm saying is what we do should be medically correct and ethically correct, then you can defend. That is only defense, that you're ethically correct and you're documented.
Sir, it is expected from us that we should be accurate, honest and ethical. And most of the time I think these three things are not possible, sir. Because family says, sir, उनको मत बताना, जैसे सर ने बोला कि
नहीं, अगर ऐसे कुछ see, मेरे पास भी ऐसे लोग कहते हैं, उनको मत बताना सर. मैं कहता हूँ, देखो क्यों ऐसे कह रहे हो? No, next question, तुम क्यों ऐसे कह रहे हो? Okay. Then they come out with their emotion. When the emotion के लिए तुमने एक safety valve दे दिया, then they calm down and then look at it differently. What I'm saying is, as I think many of us have said, the communication skills we have to develop, and it was pointed out that we don't get any grounding as a student or as a postgraduate student. The time to change the paradigm is now. There are structured ways of improving communication. Now there are so much literature. There is so much evidence basis now. Evidence basis. And now in the US, all these certificate exams, they include a structured training program for communication. It is required for those people in office practice, involved in hospital practice and ICU practice. So if somebody says like this, you have to, the next appropriate question is, why do you say so? Can we talk about it?
That's my next question to Dr. Purvish Parekh. Sir, you have been practicing oncology for last so many years, and you must have been talking to the family members. So do you think audio, video consenting and counseling of the family members is something that has to be done daily, on a daily practice? Like आप rounds के बाद आते हैं, कितनी बार ऐसा होता है आप लोग जल्दी में होते हैं और आप ICU के बाहर ही मरीज को हाँ सब ठीक है या बता दिया हमने उसको बता दिया, and you know we are in a rush. हमारा intention नहीं होता है कि हम मरीज को ignore करें, but हम बैठ के कमरे में एक audio visual room में बैठ के बात काफी बार नहीं कर पाते हैं. Do you think that we should do this?
We should do this, yes. Should we do it daily? No, absolutely not. This is at a critical time in the treatment decision process where you want the entire family to be on board and you want a consensus. That is the time when you should do it. But today the patient's pulse is 110, tomorrow the patient's pulse is 115. So should I do it again? Absolutely not.
So studies have been done and they have showed that there are two groups of doctors, and one group of doctor is standing in the lobby and giving the update of the patient, and another group of doctors is giving the update of the patient sitting in the counseling room. The time taken is less when they are sitting and talking, because the perception of the family is कि हमें अकेले में time दिया, बैठ के time दिया, and they take sign of the family member that yes, we have communicated this and this to you. So sir, do you think that audio video counseling should be a part of our daily practice, and how can we incorporate that? I know it's difficult with the time.
My feeling is, and I'm going to play the devil's advocate here, video counseling is a double-edged weapon. Okay, it documents critically what you have not said, and that is what the relatives or the lawyers will pick up and say, why you did not say this. In a terminal or critically ill patient, there could be 1001 complications. So I would never do a video counseling unless mandated by law.
Right.
This is a very interesting point. You see, I also learned this, that video is not a great idea. It's a double-edged sword, as Dr. Sab said. You see, the thing is, firstly, you cannot do a video recording unless you declare that to the family.
Yeah.
Okay. Otherwise it's that is also not proper legally. And you can't cover everything. That's not it. Somehow it produces a barrier between the family and yourself. Okay. Being overly legal doesn't help us. You can do the simple things well. Write the gist of the conversation in a case notes and have them signed, or even the 3 times signing is also not required. And you can't counsel like this every day. It is at the critical times, as he said, or or at the beginning. Okay. So there are 3 stages. In the beginning, you establish a relationship. Then you give what the developments are. And third is you come to a point of critical decision. It evolves over time. It's not a one-day process.
So the health ministry has issued a draft that all the patients who are included for the trials, their audio-video consenting should be done. So that's what's your opinion?
That was there some time ago.
2018.
Now it is taken off. Okay. So the video consent recording is required only for specific, very limited, vulnerable population, including transplants. So I don't think that's anything that is required as of today.
As an ECMO physician, I feel very comfortable talking in the audio-visual room because these are decisions which will be really draining the family members from finances. Around a lakh rupees per day, the expenses can go. And first of our patients who was taken on ECMO support after I came back from the UK, his son was a medical legal lawyer. And after he died, he questioned us, कि मेरी तो written में financial counseling नहीं हुई थी. That was his question. After that, we made rules for the financial counselings, and all the counselings are done under the audiovisual recording. And obviously, we declare the family that आपकी recording करी जा रही है. So, as a critical care physician, taking such expensive decisions for my patients, I think I personally feel very comfortable on behalf of my department.
So,
That's
financial counselling is actually for the protection of the nursing home or the hospital. Okay. As far as law is concerned, we are supposed to give the best treatment irrespective of cost.
True.
Yeah. But the idea of doing a audio-video recording in a special room is also a deterrent for them to go against you in a court of law. So by saying, okay, we are going to do that, it's a good idea. But actually doing that is not a good idea.
My next question is to Dr. Saraswat, sir. Sir, you have been practicing, again, you have been dealing with critical liver failures for so many years. And you know sometimes that this patient cannot afford transplant, he's not fit for transplant, and he's dying. And he's coming to you every month, ascites lekar, SBP lekar, like lots of complications of the CLD. So have you discussed DNAR, DNI, and not for ICU ever to your patients in your clinical practice ever?
You're absolutely right that chronic advanced end-stage liver disease is generally people are in the last few months or the last year of life, and progressively the quality of life deteriorates. The cost of managing each episode of liver failure can be quite steep and very draining financially, and especially if the patient is not a candidate for liver transplant, then I think these are important questions. Now, as an outpatient, I really wouldn't get into it. This patient has a quality of life which may not be right up there, but he's still alive, he's part of the family, society, and leading a life.
My question is specific for repeated admissions to ICU.
So once they are in the ICU and they are in a terminal stage, then these discussions do happen. And in fact, one of the questions that I just asked Professor Mani was related to a similar patient. When you put them all these questions, patient is not a candidate for liver transplant, there is multi-organ failure has happened, now the patient is on the verge of renal support, on the verge of pulmonary support, ventilatory support. Do you want to do it or do you not want to do it? मरीज कहता है जी आप तय करिए, आप बताइए मैं क्या करूं, जो मेरे मरीज के लिए अच्छा हो वो मुझे करना. So I mean these are the kind of discussions we have had, and I guess That's what it was a very helpful guidance from Dr. Mani, that if I am told to take the decision, then well, I'll take the decision, and after having weighed the pros and cons, advise the patient accordingly. But after that, will he actually follow my advice and not put his patient on life support? Well, that remains to be seen. Many of them, despite all the discussion and all the talk, they just do not accept. There is denial. आप जो कह रहे हैं वो बात सही नहीं है, नहीं मेरा मरीज ठीक हो जाएगा, बस आप अच्छा इलाज कीजिए वो ठीक हो जाएगा. So in that situation, well, I mean, you finally do wind up offering life support because they haven't specifically refused it. So that's how the
Sir, have you ever discussed this to your patient directly without involving the family? Like, patient आपके पास conscious आया है, ascites के लिए तीसरी बार admit हो रहा है.
That is not in itself a sufficient indication. 10वीं बार भी ascites के लिए admit होगा वो ठीक हो जाएगा. Let the organ fail. Right. Once organ fails, then there is a reversible and an irreversible organ failure. And by the time the patient has reached the stage of irreversible organ failure, often he is not in a position, he is not have the capacity for a meaningful discussion on these lines.
So will we wait for that? Like in countries like UK, there is a form called as respect form, which is a kind of form which asks for the autonomy of the patient, that in case आपके organs fail होते हैं, in case आपको CPR की ज़रूरत होती है, would you like to have CPR? Would you like to have intubation?
So I wouldn't mind having these discussions, but I would tell you, over the years, my experience has been that patients just do not wish to discuss these issues. They will not talk or say or anything, or if they say something today, they will change their mind tomorrow. So I think this discussion we can offer them. What is happening is many Western ideas of autonomy, independence, decision making, tell me all the facts, I'll make up my mind whether I want treatment or not, of just do not operate in our society. Patients say, आप तो भगवान हैं, आप तो इतने बढ़िया डॉक्टर हैं, आप जो कहेंगे मैं वो करूँगा, आप बताइए मैं क्या करूँ. So they kind of pass off the decision to you, and which is not uncommon. And I think it is very difficult to take on the burden of all these decisions all the time. So we can make the attempt, and now and again we'll have patients who will accept and stick to their decisions, but in my experience that has been a rarity.
Right. We come to our next question to Dr. Gaurav Goyal. So question to you is, active euthanasia or assisted dying is legal in some countries under certain conditions, like in Switzerland, Netherlands. Switzerland is considered as the destination for euthanasia. I know a couple of my friends while I was living in UK whose parents went to Switzerland for euthanasia. Their parents. When can that happen? When do you think that active euthanasia can happen? And do you think one day it will be legalized in India? Can you see that? Imagine that.
Very interesting and important question. As Dr. Saraswat already said, I think our society is not so mature to take such decisions. We are still in infancy. We are dealing with a day-to-day struggle for even for free medicines, for rations. So our major population is struggling for that. So our society is so immature. अगर if as Dr. Saraswat told us कि अगर हम किसी पेशेंट से बात करते हैं तो दे से कि डॉक्टर साहब आप ही बताइए, हम उनको कहते हैं कि नहीं ऐसा करिए, नहीं डॉक्टर साहब आप सब जानते हैं, आप बताइए जो अच्छा होगा. और कुछ खराब हो जाता है तो नेक्स्ट डे वो कहेंगे नहीं डॉक्टर साहब आपने क्या कर दिया आपने, तो वो क्योंकि वी आर सोसाइटी आर नॉट सो मैच्योर. इवन वो छोटे छोटे फैक्ट्स होते हैं, इवन दे डोंट नो कि वो करना है. इवन अपन जो वेस्टर्न वर्ल्ड का देखें और अपन जैसे डेवलप्ड नेशंस में देखें तो दे स्टार्ट टॉकिंग यूथनेसिया आई थिंक फॉर 2 or 3 decades बैक. And now it's in 2016, this British Columbia and other states, they this legalized this issue, and still in states in UK, in US and even in Australia, they are in a phase of legalizing. So I think it takes 1 or 2 decades to it happens in India. First, we have to fulfill our society's basic requirements, and then once we mature on that stage, then we can take this decision. And second important issue is the this misuse of such things. Because in our society we are having different types of this are family values. Our societies are means the social issues are there and joint families are there, and sometimes this financial gain also is there. अगर somebody said कि नहीं आप यूथनेसिया ले लो, दूसरे दिन कोई उनका भतीजा कोई आ जाएगा, नहीं आपने क्यों डिसीजन ले लिया, उनके तो उसकी फलाना की प्रॉपर्टी थी वो अपने नाम कर लेगा. तो हम इतने सारे उसमें वैल्यूज में है कि आपको एक, और कई बार होता ही है तो ये नहीं करवाना है. मैं तो बोलता हूँ कि आपने तो ये कंसेंट दी थी, जैसे मैं न्यूरो इंटरवेंशन करता हूँ, आपने तो ये कंसेंट दे दी थी, नहीं वो अलग आदमी था, कुछ हो गया, कुछ क्या हो गया. तो हमारे यहाँ पे क्या कोई इस तरह का बड़ा डिफिकल्ट है. और जब वंस वी आर एजुकेटेड, वी आर मैच्योर, तो आई थिंक इट विल बी लीगलाइज्ड इन आवर कंट्री. व्हाट डू यू थिंक डॉक्टर मनी?
very interesting, important points. See, medical assistance in death is available in a few countries. It was started in the state of Oregon in the U.S. Is the first state. Now about 7 U.S. states have legalized it. Now, see how many cases come for medical assistance in death. Maybe 200 cases in the last 20 years. Right? So it is not that everybody is going through this. It's an option available under certain strict safeguards. First safeguard is medical assistance in death can be requested only by the patient himself. This means there is no surrogate. Medical assistance in death doesn't happen in the ICU. It happens in the office practice. It has to be done, and with 2 doctors consenting, and there has to be a consistency in the request. There is a lead time, 6 months, 1 year, something, there's a lead time. So it's under certain strict safeguards. So we don't even understand the difference between euthanasia and withdrawal and withholding. So obviously, as he says, we are not a mature society ready yet for the concept of MAID. We might get totally confused. We might conflate withdrawal withholding decisions with MAID decisions. Okay, made decisions. So this is not something I would like to tackle at all. I'm in the I'm doing this advocacy for a long time, but I won't touch MAID now. It is strategically wrong. Because let's first understand withdrawal, withholding, and simple normal medical practice when you can refuse treatment, when you can. No, these are normal medical practice in most places. They don't need legislation actually for this.
Right. Okay. Our last question is to Dr. Sudha Sarna, ma'am. Ma'am, you are a palliative care physician, and there have been certain incidences in the recent 1 year where we have done withdrawal of care and end-of-life care of some patients in our ICU, especially during the second wave of pandemic. There were patients on ECMO who were on ECMO for 1 month, and we did withdrawal of care. So, ma'am, how can doctors be ethically correct and medically safe around withdrawal of care and end-of-life care?
Thank you. I think when any treatment is not beneficial for patient, it is ethically appropriate to withdraw it. And Code of Medical Ethics states that if a patient who has decision-making capacity, he has right to refuse to any kind of treatment, or he has a right to stop to any kind of treatment, even when that decision is going to lead to his or her death. So we should be very careful regarding these things, and we should take medical legal safety in view also. In such cases, the futility of the treatment, that is, the treatment is no longer effective, should be explained to the patient. This is done by a clinician, and there is a second clinician who is not directly involved in the patient care, and third is the nursing officer. So these 3 people, they can sign, they can make a, they can give you a insight that treatment is no longer going to affect the patient significantly. Then after getting this from the clinician, this is to be communicated to the family properly, and doctor has a responsibility to communicate every relevant medical information to the patient. He should be transparent, he should be honest. When consensus is being made by doctor and patient or family that yes, we can stop the treatment, then end of life care decision should be made. End of life care decision, we have a policy in our institute also, and once it's made, I think it's very important because we want our patient to smoothly transmit from curative to palliative care. We talk about comfort care. That is what patient needs that time. Patients should be comfortable. So end of life care then be initiated, and this is to be explained to the patient, documented to the patient. If patient and its family, it should be documented, and our main aim, it should be assured also to the family that patient will not be deprived of any medical care. He should continue get the medical care, and this should be assessed periodically to see its effectiveness. At some point of time, doctors may feel that you have to revert to the curative care. So this should be also explained to the patient, and this should be documented. And I think end of life care should be given to every patient. It's the human right.
Thank you so much, ma'am. On this, we conclude our panel discussion for the day.
A couple of minutes to respond to Sudhaji.
Yes, sir,
wonderful
please.
points. 2 points I must say. What is the difference between palliative care and hospice care? Palliative care is there at every step of the way. It doesn't need an end of life care. End of life care, palliative care starts much before and comes to end of life care, goes beyond death also to bereavement. So it is a approach. Palliative care is a perspective which is more holistic, and it spans the entire clinical course of the patient. And in the ICU, initially curative care dominates, but there is a bit of palliative care when you are giving sedation, analgo sedation, part of palliative care. When you are treating delirium or preventing delirium, then it gives way gradually as you see the trajectory going towards a non-curable state. Then palliative care predominates, and then that takes over in end of life care, and then continues to breathe. Second point, madam, you said something very important. Forgotten.
All right. I would invite Dr. Lalit sir to please come here. And thank you, sir.
So with this, we come to the end of today's session, and may I request Dr. Manish sir to please stay and to honor our 2 foreign guests, Dr. Anjum. They have left, our foreign guests also have left. So there is a good news for all of us that there is high tea, and you all will get double of what we have planned. So with this, we end up today. Thank you so much. Thank you, Professor R.K. Manish sir. Thank you all the faculty, sir.